So good afternoon, everybody, and welcome to the English Diabetes Foot Care Network, our third conference. We'd like to say thank you very much to our sponsors of this year's conference, and we're pleased to have received support from Scholl and from Therametrics, the manufacturers of Podium Thermal Foot Monitor. I think we've got a very interesting afternoon ahead of us. And as we go along, if you have any questions, please put them into the Q&A box, and I will do my best to get through those as we go along. So first off, we will hear from Nicole Mottolini, who is going to talk to us about NHS Resolution. Nicole is a clinical fellow at NHS Resolution who's undertaken a national review of clinical negligence claims involving patients with diabetes and lower limb complications. Nicole also works as the safety and learning lead for the Midlands and East region. So over to you, Nicole.
Thank you very much, Richard. I will just share my screen with you all, and hopefully that's come up nice and clear. So good afternoon, everyone. Lovely to see you all and to be here today. As mentioned, my name's Nicole Mottolini, and I work at NHS Resolution and have undertaken a review of clinical negligence claims involving patients who have diabetes and a lower limb complication. I'm going to give a little bit of background overview today as to some of the general principles and aims behind trying to learn from and utilize claims information. And then I'm going to talk through the findings that have come out of this particular claims analysis. So I'll give a summary of the themes, the findings, and the recommendations that have been produced alongside this project. So just by way of quick background, NHS Resolution is part of the NHS. It takes its directions from the Department of Health and Social Care, but it's what's known as an arm's length body. So it does function somewhat independently. Essentially, NHS Resolution is the organisation that steps in to offer support if a clinical or a non-clinical negligence claim has been made against the NHS, be that a community, acute, a mental health trust, or a primary care provider, and they offer support to try and help to resolve that claim as quickly, as fairly, and as cost effectively as they can. Alongside that aim of trying to resolve claims as fairly as possible, the other core aim amongst the organisation is to help to try and ensure that as much learning has been drawn from those claims as possible, that we have as much understanding as we can as to the causes, the contributing factors behind why those claims have occurred, to then be able to share that learning back across the healthcare system as widely as possible, with the ultimate goal being that that learning can help to contribute to improvement in patient safety, improvement to care, a reduction in harm, and of course linked to that is a reduction in clinical negligence claims. So hopefully there is quite a clear patient safety driver or incentive behind why we want to learn from and reduce claims. Alongside that patient safety, that human cost incentive, is the additional financial costs that are associated with clinical negligence claims. And you might have seen some of the headline figures that crop up from time to time, quoting the very significant and often reported as being unsustainable costs that are associated with not just paying compensation to families and their patients' families and their friends, but also on their behalf, but also the significant legal costs that can be associated with claims. And these are costs that we ideally want to try and preserve to actually deliver clinical care in the first instance. So hopefully that is quite a powerful additional incentive behind trying to understand and then use that understanding to reduce claims. When we talk about learning from claims and trying to understand the contributing factors to why a claim has occurred, we can focus on both the clinical care that was provided as well as our response to that clinical care, and try and recognize if there is anything different in that response that might have reduced the need for escalation to the point of a claim. And this is off the back of research that has been undertaken that shows that the key motivating factor for patients or their family, friends on their behalf choosing to actually pursue a claim is not necessarily driven just by a desire to seek compensation. often the determining factors are through a desire to have an apology, to have an explanation, or to have some assurance that what happened to them won't actually happen to someone else, as being some of the key reasons why a patient would decide to bring a claim forward. But if we think about those three elements around apologizing, making genuine changes, and giving a genuine explanation, they really form what encompasses a fair response to harm, and they shouldn't need to be delivered only at the point of a claim. They should be able to be delivered much closer to the point of incident, which hopefully, again, reduces the need for that escalation to a complaint and then to a claim. So that is why when we talk about learning from harm, learning from claims, we encourage a reflection that doesn't just stop at just the clinical care, but actually our response to that. And within that aim of trying to learn from claims, the organisation has undertaken a number of targeted reviews into claims covering a specific topic. And this is where the topic of diabetes and lower limb complications and the project arose. There are a number of potential contributing factors as to why the organisation would choose a particular topic to look into, be that the value, the volume of associated claims, the human cost attributed to those claims. And for this particular example, and just sharing this information with you with the heavy caveat that diabetic and lower limb related complication claims do not have an exact corresponding code. So to find the exact conclusive total value, total volume, exact figures attributed to this group of claims does come with some challenges. But sharing alongside that caveat, what we have been able to see from the analysis undertaken is that this is an area that does seem to be associated with significant volumes of claims, with claims that seem to be also rising in volume, and also with associated significant costs. These are claims that can be attributed to costs of £1 million or more. So there's significant value associated with this. Also sharing with this strong caveat, when we're looking more generally at just lower limb amputation claims, so not specific to diabetes or non-diabetic, but again, looking at these claims overall, they do seem to feature quite highly on tallies looking at overall claims volume. So if we're looking at overall injuries, lower limb amputations generally do feature quite highly. And even more specifically, if we look at different categories of claims, particularly claims arising from community environments, from community trusts, lower limb amputations seem to feature even higher. So within the top 5 overall top injuries for all claims. So they are claims that are associated with a significant value and volume of claims. Additionally to that value and volume, of course, it is a pathology that's associated with significant human impact. And again, the organisation recognised that perhaps being able to look at this topic through the lens of clinical negligence claims might help to provide some insights and to some support to the wider brilliant work that's occurring, trying to raise awareness and improvements around this area of clinical care. So on that note, as a bit of initial just background to where this project arose from, we looked at just over 90 closed clinical negligence claims, all involving a patient with diabetes and a lower limb complication. And the aim was to look at these particular group of claims in much more depth. So trying to draw out some of those clinical qualitative themes, as well as just providing a picture of the overall costs and volume. And in looking at these particular claims, we tried to look at as much of the entire patient journey as possible. So not just the care involved in the alleged negligent example, but also what happened before, what happened after. And for me, one of my personal takeaways in looking at claims was that this was a real benefit, because you were able to clearly see some of those more systemic factors and get the perspective of different teams that might give input along the way of that patient journey. So to give a summary of those findings, starting with preventative care, so before a problem arose, and what we saw in the claims is that the majority of patients should have fallen into the high risk category in regard to their foot health risk status, yet very few patients were clearly identified, labelled, or advised themselves that they were high risk. Very few patients were receiving any preventative care or any consistent preventative care in the form of input from a podiatry team, education, advice about how to safely self-manage their own risk factors, advice about footwear, etc. When a problem did arise, there were delays in referring patients from the primary care teams into the specialist foot care teams, but there were also delays from the specialist foot care teams in actually seeing the patient once that referral had been received. We also saw that the primary care teams needed to send multiple referrals, often chasing up those referrals in order for the patient to be first reviewed. Once referred to and under the specialist foot care teams, we saw that the primary care teams were still quite heavily relied upon to provide core aspects of management, namely around prescribing antibiotics, seeing the patient as an emergency, referring for admission, referring into vascular or orthopedic team, or also referring into different teams within what should have been that same foot care pathway, so from community into acute or vice versa. This overall meant that it was very confusing to who was responsible for follow-up specific actions and who had overall responsibility for coordinating that care of the patient. In regard to management-specific pathology, particularly diabetic foot ulcers, key aspects of management were performed, again, inconsistently, not particularly thoroughly, late in the progression of disease, or at times not at all. So, for example, wound classification systems were very infrequently used. There was very minimal evidence of debridement, of taking a sample for microbiology review, of performing probe to bone or depth assessment, of undertaking imaging. And on top of all of those aspects of care that were missing, the most commonly neglected element was around biomechanics and offloading. There was very little biomechanical assessments performed and very little offloading, let alone evidence-based offloading performed. It seemed to be that amongst clinicians of all disciplines really, that mechanical features and the impact that they would have on the likelihood of ulcers developing and or healing just didn't seem to factor into their considerations. In regard to pathways to escalate patients into hospital, these pathways seem convoluted with lots of clinicians involved along the way, often all of those clinicians reaching different conclusions as to the reasons for admission and the plan once admitted without anyone picking up on those discrepancies. Likewise, pathways to facilitate that continuity of care once discharged patients from hospital didn't seem to be in place either, with lack of clear pathways from inpatient teams down through acute, community and primary care. We saw that often there was little evidence of healing prior to discharge from hospital, and following discharge there was often evidence of deterioration shortly after, with lots of patients involved in the claims requiring more than one admission for the same pathology, each admission the pathology being worse on each admission. Likewise, when we're looking at pathways relating to the management of peripheral arterial disease, we saw delays at every stage of these pathways as well. And by the time the patient underwent an intervention, they seemed to be in a worse situation clinically, with more tissue loss, worsening infection, therefore less chance of a good outcome in comparison to even the point where that decision was made to undertake that intervention. The vascular teams and the specialist foot care team did not seem well integrated, very infrequently performed joint reviews, and didn't also even seem to have ease of communication channels between those teams. Thinking about education, psychological support and patient compliance, there were certainly examples seen in the claims that could be described as lack of compliance, lack of ownership on the patient's perspective. But again, there was very little evidence of education provided, let alone delivered in a way where we could measure the effectiveness of that education and whether it was taken on board and understood. There were also lots of hints in the notes that potential emotional or well-being issues, typically around low mood, potential dependency issues, family troubles, but these weren't followed up with further consideration as to whether the patient might benefit from more formal mental health assessment or support to be able to comply. Across all of those stages of management, the common recurring theme seen amongst the claims was that there was missed recognition of severity of the situation that the patient was in, and they were not treated with any particular urgency at any stage in care. Again, a couple of factors seem to contribute to this missed recognition of severity, with terminology and language being a really key theme. The fact that between different, or the fact that the language used to describe the same patient, pathology, or situation was very nondescript, inconsistent, and overall didn't allow us to clearly ascertain if the situation was actually improving, deteriorating, or staying the same. Peripheral neuropathy seemed to be another really key barrier in patients not triggering that urgent response in the clinicians looking after them, and also seemed to highlight a potential gap in education and the way it is delivered, potentially in theoretical knowledge versus practical application. We know that most clinicians, regardless of the discipline or the profession they belong to, are probably aware and can volunteer that yes, diabetes causes nerve damage. But what we saw in the claims is that when they had patients infantilizing, vocalizing those all too commonly heard phrases around, this doesn't cause me pain, I can walk okay, I drove okay, that really did seem to trigger reassurance rather than that alarm bell recognition that this patient might have peripheral neuropathy. Finally, another really key theme amongst the claims was that while there were multiple disciplines involved in the care of the patient, this certainly didn't naturally equate to integrated multidisciplinary team working. And overall, a change in the clinical picture of the patient wasn't met with a change in the management plan. And this again seemed to be contributed to the fact that there wasn't one clear team seemingly responsible for ensuring that there was a management plan. Secondly, that the management plan was adapted or changed or escalated if it clearly wasn't working. And this links to one of the core recommendations that have been produced alongside this report, which is around trying to ensure there's some agreement, clarity, and standardization as to what we mean when we say a multidisciplinary foot care team. Because again, reflective of the themes involved in the claims, there seemed to be huge variation across different teams and across the country as to the remit, the clinicians involved, the frequency of reviews in terms of the MDTs that were involved in the care of the patient. The common feature of those MDTs, however, seen in the claims was that they were not the primary team actually overseeing the care of the patient, and they didn't seem to be the team that had that overall accountability, responsibility, or ability to ensure that there was one holistic management plan that was being followed and that was in place. So to give a very brief overview of the recommendations, and I'll just run through these in summary. And again, the recommendations that have been produced are with the aim of reflecting the themes that were in the claims. But we also very much want to acknowledge and just reiterate the gratitude for all of those that gave their expertise and advice and support to help us to ensure that these recommendations were as practical and realistic as could be. And we also wanted to acknowledge that we recognize there are a lot of good national publications out there that produce good recommendations, and we certainly support these current recommendations and guidance. What we reflected on, however, is that there were principles of care within the current guidance that were not applied consistently to the patients involved in the claims, and we tried to consider what would be needed to be able to apply current guidance more consistently. And one of those key recommendations is around education and training, and that's education to both clinicians and also patients. And if we think about, again, the themes involved in the claims and the lack of clear education that was given to patients at all, let alone in a way where we actually had the specifics and the right information as to what type of advice or what type of evidence were given, it seemed to be a key barrier in us being able to build our evidence-based and build our understanding as to what type of education delivered in what manner actually has the best chance on impacting on outcomes. And that is why within this recommendation, we're hopefully calling for just some fundamental standardization to get that first step right, where we are all clear when we say provision of education. We're clear on what that means in terms of who's delivering that education, when they're delivering it, in what format, and very importantly, how is that education being recorded, so that we can monitor how that education actually links to outcomes. And one of the key take homes for me when I was doing this work, and one of the personal big takeaways, was just thinking about not only the advice or the education we give and whether it's right, whether it's good enough, but actually whether we need to think about whether it's enough to override potentially other messages patients receive outside of our services that might contrast with some of the messages we're trying to get across to patients. And personally, coming from the perspective where I've been able and fortunate to work in teams where we're able and we do give advice, but perhaps being a little bit bewildered or at times frustrated, and hopefully I'm not the only one that shares this sentiment of wondering why some of the advice that we give doesn't seem to be taken on board by patients to the extent that we would hope. But what really struck me looking at the claims is that outside of the advice we give, some of the messages the patients receive might be a little bit in contrast and might actually impact on patients' ability to follow our advice, regardless of how good it might be. So one example I often share when talking about this work is the case story involving a patient who was seen by the hot foot clinic, had a infected diabetic foot ulcer with ischemia, and a plan was made to admit that patient into hospital. The patient themselves decided that they didn't want to stay overnight and elected to come back the next day, which we could say is an example of lack of compliance. However, looking at the claims and looking at the care that was provided just preceding that event and in the lead up, this is a patient who very recently before that had been told that they had athlete's foot, and the conclusion from the appointments outside of the specialist foot care team in the lead up was very much around the conclusion of this should resolve, come back if there's not a problem. So that is probably going to result in the patient not necessarily associating this pathology with something that could require admission and might influence on patients' ability to comply. So of course, linked to that is considering how we provide education to clinicians as well, ensuring that, again, it's not just the theory, but that practical application that is correct, ensuring there is an understanding of how these patients might present in practice, and giving that perhaps clearer warning that they might be a patient group that doesn't necessarily make it really obvious for you that the situation might be serious, trying to instill that curiosity and that suspicion in clinicians. And again, that's reflective of a common theme seen in the claims, where clinicians seem to really look at the pathology as it was, as a snapshot in time, without that consideration of risk factors, history, or the pattern of progression. So education, the type of education, a really key theme. Looking at pathways and the provision of consistent services, and again thinking about how we can ensure current pathways, current guidance at either a local protocols or more a national level, national guidance can be applied more consistently. And hopefully, as a reasonably simple recommendation, involves just ensuring we include clear definitions for the pathologies we're referring to. So what we saw in the claims is that, for example, there can be an array of terms, some very creative as to the way we describe a diabetic foot ulcer. So even if the guidance relating to diabetic foot ulcers is clear, well promoted, well known, if we don't first identify pathology as such, it's not going to be applied consistency, which may have been a reason behind why that guidance wasn't applied to the patients involved in the claim. So if we're talking about diabetic foot ulcers, limb-threatening emergencies, that we're really specific as to what those pathologies mean. Likewise, trying to reduce possibilities or opportunities to have varied interpretation of guidance. So recommending we avoid use of terminology and guidance such as if concern or if suspect. For example, if concern deep-seated infection, consider certain imaging, because there seems to be a lot of subjectivity across clinicians as to what would actually trigger concern. So instead, giving very clear specifics as to the assessments that should be undertaken, the results that should be gathered, to then look at that evidence and use that evidence to more subjectively conclude if a pathology may or may not be present or determine the severity of the situation. We have a dedicated recommendation looking just at this, at biomechanics and offloading, again, reflective of this being one of the most commonly neglected aspects of care in the claim. And linked to this recommendation and to a broader recommendation more generally is the role of commissioners in actually being, having that input and that coordinating role. And again, looking at examples of care seen in the claims where we have individual teams, individual clinicians who are no doubt doing their absolute best, but seeing that individual teams along the patient pathway aren't actually able to see all of the patient information and are not actually able to make a management decision. And we therefore refer to a lot of the care provided in the claims as being resource heavy but outcome light, where from all of that input, there's very little clear action plans and follow-up outcomes that are made. So trying to get that support from commissioners and help them understand the potential cost saving and cost effectiveness of helping us to just get that coordination across the system, across all those different teams. Finally, just to summarize very briefly the last three recommendations around a public health campaign and trying to support improved awareness and a reduction in variation from the patient group up, recognizing the importance of a sustained workforce. And again, this is obviously a topic that's quite important across the healthcare system more generally, but thinking about things that might support retention of clinicians, including making sure there is that ability for clinicians to progress into those decision-making roles where they can have that influence over patient outcomes, very much because that clearly is from the claims reviewed is something that was missing and that was needed by patients, and also to support that, again, career, that retention of experienced clinicians. Final recommendation is aligned to one of the key aims at NHS resolution around trying to ensure a learning culture can be a business as usual element of providing care. And again, trying to get the support from service managers to commissioners to allow teams to have the time, the resources to undertake review of services. And again, perhaps supportive of that argument to ensure that that support is there is through the evidence we have that, again, a team that has the ability to reflect on the care that's provided, make necessary changes, and has a general reflective cycle built into the way they delivered care, shows it has, from the evidence, suggests that that is an aspect that might contribute to a reduction in clinical negligence claims, and therefore there might be cost-saving elements associated with having that reflective practice built into services. Very finally, and I won't go into any detail, but just if individual teams would like to try to consider looking at their local claims profiles as part of their service audits, all claims for each organisation are stored in something called a scorecard. And these scorecards typically sit with legal personnel within trusts, and there is some variation as to how the legal teams interface and share that learning with clinicians, but that sharing of learning is definitely something we encourage. So if that is something you would like to look at within your organisation in more detail, we usually recommend in the first instance approaching legal teams to try and have access to that scorecard. And again, I can talk through that in a bit more detail with anyone following this. So I've nearly reached the end of my slot, so I will stop there, but I just wanted to say thank you very much for listening to that presentation, and lovely to see you all today. So thanks again.
That was great, thank you. It's an amazing piece of work, Nicole, and I think it really highlights areas that we need to do a bit of more work on, to say the least. We've had a question through really about offloading and the amount of evidence to support that, and I think that's possibly in different types of devices. Did that come up at all, or was it just a lack of offloading altogether?
Yeah, it's a difficult one because within this topic, there seemed to be just a very general lack of any offloading at all, or any information in the notes about if offloading wasn't attempted or wasn't provided, the decisions behind why that wasn't the case. So it was very difficult to explore that topic in any further depth, other than to say it just seemed to be an element of care that wasn't really given much consideration. There wasn't a lot of importance seemingly placed on biomechanics or offloading in general, and where we tried to stress that had an impact is even in those examples where we got other elements of care correct or performed quite highly specialized, costly interventions. So revascularization, 6 weeks of intravenous antibiotics, things like that, that then wasn't followed up with a holistic plan that included offloading. And despite sometimes surgical success, we didn't see evidence of clinical success. So it's really just part of trying to ensure that we are not forgetting this really important element of care.
That's brilliant. I think from some of the points you've made, hopefully we'll get these covered in the next couple of talks, because I know pathways is something within the NDFA, and actually looking at that variation being created by having diabetes as the lower limb issue, and actually we know that there's a broader problem here with people who don't have diabetes and amputations, and hopefully we'll hear more about that with the National Wound Care Strategy Programme. So that was brilliant. Thank you so much.
Thank you.
All right, so we should move on now to an update from the National Diabetes Foot Care Programme. We have Professor Fran Game with us. Fran is Consultant Diabetologist and Clinical Director of R&D at University Hospitals of Derby and Burton NHS Foundation Trust. And Fran is the Clinical Lead for the National Diabetes Foot Care Audit in England and Wales. Thank you, Fran.
Thanks, Richard, and a particular thank you from me to Nicole. Actually, that was a superb presentation and reflects quite nicely with my own. Actually, there's some very similar points brought up. Let's hope that the slides advance this time. They do. Now, the first thing I want to say is, although I'm talking about the National Diabetes Foot Audit, what I'm actually talking about is benchmarking, because it always seems to me that an audit is something that is imposed from outside. The definition in the dictionary is an official inspection of your individual organisation's accounts or processes, typically by an independent body, whereas I very much think, and this is reflecting on something that Nicole said in her presentation, actually, that we should be thinking much more that this is a benchmarking approach. So there is a standard of excellence to which we should all aspire, is an achievement, and against which we measure ourselves and we reflect on that. So although it is called an audit, so it seems like a very dull set of numbers, I very much hope that you will see at the end of this that it's a benchmarking and something we should all be involved in. Why do we need it? Because there's huge variation across the country. I change this slide depending on how I'm feeling. Sometimes it's the slide of total amputations, sometimes it's minor amputations. You can cut it any way you want, but this is actually the slide of major amputations. This is actually from the most latest data from the National Diabetes Foot Audit. So taking us up to 2021, this is regions, so you don't see the full effect of the variation, but even if you take a massive geographical area like a region, you can see the variation in the outcome of people who are registered on the National Diabetes Foot Audit. So usually that means that they are attending a service where people are interested in the subject. And despite that, there is a threefold difference in the outcome in terms of major amputation of a severe foot ulcer within 6 months. And I think that's unacceptable, and I'm pretty sure the patients think that's unacceptable too. Within those big regions, there's even bigger variation than that. So what is the National Diabetes Foot Care Audit? Well, it's a national audit. England and Wales, Scotland isn't part of it. It was started in July 2014. It's part of the umbrella of audits of the National Diabetes Audit family. And the aim is to measure the factors associated with outcomes in people with diabetes foot ulcer. And this is for use by service providers in particular, but also local commissioners and national policy makers. And it's really useful, a really useful tool to help us provide better services for our patients. So we share information according to best practice, and to make sure that we're all aspiring to the highest possible standard of care, which is what our patients expect of us. So it is linked to the core audit. About 95% of people with diabetes will be registered in that core data set, because the data is sucked from GP computers through people's NHS number. And so when a person is registered with a GP and has a flag of diabetes, their data is sucked off on an annual basis. Actually, it's quarterly basis for the NDA, and all of their basic demographics, ethnicity if it's recorded, HbA1c, whether they've had their feet checked, all of those important key care processes for their diabetes are incorporated within that. And that makes it very easy for the smaller audits, the more specialist audits, to link and get a whole load of data that we would otherwise be filling in loads of forms in the clinic. And it means that our data collection is very simple. We really only collect the things that wouldn't otherwise be collected in the GP systems, primary care systems. So this reduces inaccuracy. I mean, you know, we might write down that somebody's HbA1c is this because it's today, but it might be GP might check it again tomorrow. It might be different. So everything is accurate. It means we've got less missing data, and it increases the participation. And so what we collect is each new ulcer episode. So that's not each new ulcer. An ulcer episode occurs when somebody develops an ulcer who has previously been ulcer free. So they can be, you know, registered more than once. If somebody has had an ulcer, or 2 or 3, they've all resolved, they've become ulcer free, but they get another ulcer, that's a new ulcer episode. And the data we record are the NHS number, so we can suck all the other data off. Most importantly, the time from first presentation of the ulcer to a healthcare professional, and the time that they're seen, but in the specialist service. And this is often badly completed, I have to say. It's a rather confusing concept. But if the patient's been to A&E, or if they've been seeing their practice nurse, or, you know, a service that you wouldn't consider part of your multidisciplinary specialist diabetes foot care team, and that person sits and has antibiotics from a walk-in unit for 6 weeks before they come to you, that's the date that is recorded in there. We also record the ulcer severity, and that's using a SINBAD score. This is an audit tool, and so it's very simple. It just gives you a 0 to 6 score. Although having said that, when I heard what Nicole was saying, it's not in any detail. I'll show you the SINBAD score in a second. It's not detailed at all. But if you think about all of those 6 items, you will not miss too much in terms of the patient's management going forward. And then the simple clinical outcome of whether the person is alive and ulcer free. So all ulcers need healing at 12 weeks. Previously, we've recorded 24 weeks, but simplified in the last couple of audits to just 12 weeks. And then, as I say, everything's linked to other databases. So that's the NDA, ONS, and for the Welsh sites, HES for PEDU, and HES for the English sites. So this is the form that gets filled in. It is really a really simple form. As you see, it just says whether the index ulcer is the right or the left. Charcot we was just for interest. It's not, it is collected, but we don't do much about it. Is this the first ever foot ulcer? So now we're looking at multiple or previous ulcers. That'll be analysed in future data. But these are the 6 SINBAD scores here. Is it forefoot or hindfoot? Does the patient have ischemia? That in itself should trigger some management differences. Does the patient have neuropathy? As Nicole said, it's very rarely recorded in any particular way. And obviously, if the patient then has a plantar foot audit, also that may then trigger the need for offloading. Is it infected? Is it big? Does it go to bone? How can you say it goes to tendon or bone if you haven't done a probe to bone? I'm staggered. So all of these things will enable you to even think about the ulcer outside the audit. Although this is an audit tool, I must remind you, it is only an audit tool. But I think it is a useful way of ensuring you do cover all the basics in your clinic. and then the alive and ulcer free. So how well are we doing? Well, since 2014, since the ulcer started, we now have over 100,000 ulcer episodes registered. It is now the biggest continuous audit of diabetes-related foot ulcers in the world, and those ulcers existed in 76,000 people. So we've got a huge population of people with diabetes as well. And as you can see, as people got more familiar with the audit, there was a bit more of a takeoff. This is the COVID year, when many services sadly closed, but we're picking up again this year. We're back on the previous trajectory as I see things being registered. But the last data collection analysis was the end of 2021. That hides, as always, a huge variation. So these are the percentage of people with diabetes who are registered on the diabetes foot audit. Now, what we don't know is actually what the denominator is. We actually don't know how many people with diabetes should have or would have or can have or exist having diabetes related foot ulcers. We're guessing around 2% of the population. We don't know. In Scotland, they think it's 1% of the population of people with diabetes. We actually don't know. But what I do know is there's not a tenfold variation across the region in the incidence and prevalence of diabetes-related foot ulcers. So this shows that actually this is a registration problem, not necessarily an incidence problem. And if we don't upload our data, we can't benchmark ourselves and get better. Now, this blobogram actually was published in 2014 on the NDFA data, and I'm not apologising for showing it, because actually it's a really useful visual of which variables actually contribute to worse outcome in these patients. And it hasn't changed. We haven't republished this blobogram, but as I say, it's about the same if we had done. It takes a lot of work to produce these graphics. But what I did want to show you was that the fourth most common and largest variable that is associated with poor outcome is time to first expert assessment. And if you've heard anybody talk about the National Diabetes Foot Audit, time to first expert assessment comes up time and time and time again. And these are the most recent data. In every iteration of this audit, it has shown the same result, that the longer it takes somebody to be seen by a healthcare professional to get to a specialist team, preferably a multidisciplinary team, who know what they're doing, the worse is the severity of the ulcer, and the worse the severity of ulcer on arrival at the MDFT, the worse is the outcome. So this is being alive and ulcer free by ulcer severity, so that's 3 or more on a SINBAD score. So if you present with a severe ulcer, you are much less likely to be healed at 12 weeks. And you can see by almost, well, twice, you could say, double the association with not being alive and ulcer free in that period of time. And this, of course, means that things are become quite expensive for healthcare providers and healthcare systems, because the longer it takes to heal, the more resources have to go into treating that patient. And actually, the longer an ulcer is open, the higher the risk of an adverse outcome, such as amputation. So time to first expert assessment correlates with severity of ulcer, correlates with poor outcome. So how are we doing? Because we've been saying this now for 6 or 7 years. Well, not too badly, actually. The first expert assessment at within 13 days, so that's less than 2 weeks, has been increasing over the years from 60 to 70%, not as rapidly as I would like it. And the severe ulcers at presentation were coming down. This, sadly, is COVID. And hopefully they'll continue to on the downward trajectory as we go through. So we are improving, obviously, subject to variation. So these are the regional data, the same thing, the first expert assessment within 13 days. The white line across all these graphs is the England and Wales national average, and these are the regions. And I probably don't need to labour the point. Anybody, you always look at your own region, don't you? Instantly, you gaze at your own region. So I'm pretty sure that those of you in the West Midlands have already seen that graph, but most were moving in the right direction. And so what about the outcomes? That's the first expert assessment. What about the outcomes? Well, the proportion of people being alive and ulcer free actually was improving, but as I took a little bit of a downward turn during COVID, and we hope that that will now uptick as we're out of COVID and there is restoration of services. The number of active ulcers again was coming down. This is 12-week outcomes. We'll talk about mortality in a second. But again, this is all subject to variation. I'm going to show this in various ways. This is a funnel plot. So this actually also looks at the number of ulcers that have been uploaded. So at this end of the scale, you've got some centres, some providers. This is by provider, not by region. Providers uploading quite large numbers of ulcers. And so this means we can be fairly confident that they're about their healing ratios. Obviously, when you get down to this end of the scale, there's quite wide confidence. If you only upload 3 ulcers, we can't be sure whether you've uploaded 3 bad ones, 3 good ones. So the width of this funnel plot actually tells us what the confidence in that is. But even given that, there are some centres who appear to have extraordinarily good outcomes, some providers, and equally some providers who seem to fall well below the national average. The people who upload the most ulcers actually do seem to scatter around this line. And the Welsh providers, well, we're talking to the English Diabetes Foot Network here, but the Welsh providers do seem to fall on the lower end of that line, but they are always smaller centres, and so we have a little bit less confidence in that result. So I've put a question mark on here. Is the delivery of care as variable as the outcome? I think I've probably given you the answer, and certainly the delivery of the care is as important to the outcome as anything else. And with this in mind, talking about delivery of care, this is the major amputation blobogram. Again, this is based on 2014-2015 data, but actually hasn't changed. We just haven't reproduced the results. And actually what comes in here is renal replacement therapy as one of the major variables in terms of outcome. So very much thinking about delivery of care, not just about the biologics, because when we're doing benchmarking or audit, we're thinking, how can we improve our services? And so as part of the 2021 survey, we did a care structures survey through the audit. And there were some really basic questions based on findings of previous audits to see whether actually people are reflecting and improving their services, not just the providers, but the commissioners and those that buy the services. And I just want you to look in the top ones here. And that is, does your provider have a dedicated multidisciplinary foot care service? And 91% of people said yes. Now that doesn't mean to say it functions as a multidisciplinary foot care service, as Nicole has already alluded to, but it's actually quite difficult to dig down into that and work out how those human factors work. Is your multidisciplinary foot service well integrated with a community care provider or foot protection service? And 84% said yes. And I think that's really important, again, from what Nicole has said, actually, that those pathways should be integrated. So we should know how people can be rapidly referred and how that should be integrated, not just people, but through their governance structure and their data. And the third question there is your multidisciplinary foot care service integrated with your renal service and dialysis units? Well, no wonder we've got such a big blob on our blobogram, because actually only 33% of providers said that yes, that was the case. And the fourth one on there, and I promise you, I uploaded these slides this morning and I haven't seen what Nicole had to say, but it's interesting that we're all saying the same thing. Is there regular training to ensure that people at increased risk of foot ulceration are both identified and have access to appropriate protective surveillance? So that means that there has to be training for the people who have the, I seem to have got a little message on, I hope it's not showing on your screen, have the appropriate training to actually risk assess people and give them the relevant information to ensure they get the services. Okay, so I just wanted to take you back to this slide actually and look at mortality, because this is a new analysis that we've done this year in the 2014 to 2021 service, but actually it's the first time we've actually published these data. And it's been noticed that actually the mortality of people with diabetic foot disease is increased. And this is looking at people who died actually within 12 weeks of their first expert assessments, the first time they appear at the national, at the MDFT or the specialist service. And 12 weeks is a very short space of time, as I'm sure you're aware. And we looked at some of the common complications, the multimorbidities that might be associated with that. So in the left-hand graph here, we've got those people who had been admitted to hospital. So these are quite severe episodes, admitted to hospital in the year prior to them developing an ulcer and being uploaded on the audit. And you can see that the number of people with heart failure, up to 12% of those people registered had actually been admitted to hospital. So they've got quite severe heart failure. And you see about 2% with myocardial infarction and stroke. And on the right-hand side here, we've got heart failure, myocardial infarction and stroke. So these are the proportion of people who had then died within 12 weeks. And you can see that 1 in 10 of those who had been admitted in the previous year with heart failure had died within 12 weeks. That's a very short space of time when you think actually that severe ulcers, over half of them are still open at 12 weeks. And so this makes us think about actually what are we putting our patients through? You know, should we be thinking more holistically? If somebody's mortality is 12%, is there anything we can do about that? Or are we actually thinking about perhaps some more palliative care? I don't know. These data is the first time we've published them with this audit, but it's certainly something to think about. And so on to the recommendations. We obviously, like everybody else, make recommendations at the end of this process. And so recommendations for healthcare providers and healthcare professionals. So the recommendation is that healthcare professionals should arrange early expert assessment of all new diabetic foot ulcers. And that's because we have repeatedly shown that faster referral to a specialist foot care service leads to fewer severe ulcers, which is associated with much better 12-week outcomes. And the second recommendation to healthcare providers and professionals is to ensure that healthcare providers and healthcare professionals review their national diabetes audit measures for their organisation, which means they have to upload, including the time to first expert assessment, ulcer severity and 12-week outcomes. And this is because reviewing these outcomes, reflecting on them, will help us identify gaps in service provision and potential areas for improvement. If you don't upload and you don't know, then you can't take that case of need to your commissioners. And recommendation for the commissioners is to ensure that specialist clinical services who care for people with diabetes foot ulcers are accessible everywhere. And that's also a recommendation by GIRFT that we should all have multidisciplinary foot care teams. And that is also recommended in the NHS long-term plan and in the NICE guidance. And that healthcare providers and HCPs have effective integration between clinical groups, both in the community and those with specialist expertise. And we have identified in the audit a lack of integration, and we heard from Nicole how important that is. For example, in particular, we noticed that only 1/3 of healthcare providers confirmed that the multidisciplinary foot care team was integrated with renal services. And so how well are you doing in your region? Well, I'd like you to reflect on this graph again and think, are we actually uploading? Because if we're not uploading, we don't know that we're certain about our outcomes and we can't reflect on them. And remember that I'm really thinking about benchmarking. It's about us to aspire to standards of excellence and reflect on those. So I've been using the NHS Digital logo down here because actually when these audit was created, it was NHS Digital. It's now been amalgamated with NHS England. So in the future, you'll only see NHS England logos, but actually at the time, the data report was created by NHS Digital. And at the time, the advisory group looked like this and was actually chaired by William Jeffcoat and Bob Young. And I want to pay particular homage to those because they've been leading on this since 2014. It was their baby, their brainchild, and they've brought it to fruition and done all of the background work on this. And I take it over when we've got 100,000 ulcers registered. So my thanks in particular to those, and we're looking very much at streamlining our advisory group, but also we're looking at developing an implementation group which has more regional representation. We're struggling a little bit with the Northeast, if you can see on the advisory group. So we need to be sure that we're covering the whole area of the country with our implementation arm, and we're working on that at the moment. So watch this space. And so with that, I'd just like to thank you for your attention.
That's great. Thank you very much, Fran. And interesting just how close that runs with what Nicole has been saying previously. There are a couple of questions. One from Hema Heffernan, who says, why can't we get more granular figures than 2 to 14 days? Hard to show improvement with such a wide date range.
That is an interesting point, but actually if you do look at the data, apart from those that self-refer, and that is a bit of a homogenous group, so they will often include people who've had previous ulcers and who have had a lot of education in that respect, but equally they include people who turn up in A&E who with severe ulcers who've never been seen before. So those self-referred patients are a little bit of a difficult group to pin down. So in some of those graphs, we've taken those out and looked at less than 2 days, 2 to 14 days. But actually, if you look at that, there's not a huge difference in outcome. The difference actually starts at 2 weeks. And in particular, the outcomes get very poor at 2 months. So actually, I don't get too het up about 2 days and 2 weeks in an outpatient setting. I do get het up beyond 2 weeks and beyond 2 months. So it is difficult, but if we ask for exact days, then the data become too granular and too difficult for people to fill in the form.
Okay, thank you. And I've got a question from Prad Solanki, who says, of those patients that are deceased, how many are remission patients that have re-ulcerated?
Yeah, we don't know that yet because it was only in the last set of audit forms, so that would be 2020, 2021, that we actually started including the question, is this the first ever ulcer, or has somebody had ulcers before? Is this a multiple? So actually, when you look at the data that have been uploaded in the last year, it's far less, because it was COVID, you see that drop off in the number of patients who were uploaded. It's a little bit difficult to pin that down at the moment. And so we haven't actually analysed, it has been done, but the confidence intervals are too wide. We haven't actually analysed a lot of the data on recurrent ulcer or first ever ulcer. But hopefully that will be something we can answer in the next audit, because I think we all realise that people who have ulcer after ulcer after ulcer after ulcer are probably again a different population and at higher risk. So I simply can't answer that, Prad, but hopefully we will be in the next set of data.
That's great. And lastly, question from me, which is, of those who are not ulcer-free at 12 weeks, is that due to severity or chronicity?
Again, difficult to say. Both is the answer, because chronicity develops into severity. If you don't get seen, then you don't get better. So difficult to say. The only data we have is how long it takes to get there, which is chronicity, the severity at which they arrive, and then how long it takes to heal. And there are obviously some people who present within 2 weeks, but tick all 6 boxes. They'll have a heel ulcer, vascular disease, unreconstructible. I mean, these are very broad categories, but nevertheless useful just to highlight. Getting people there often means that they don't get any worse while they're waiting.
Yeah, lovely. Thank you ever so much, Fran. That was, again, really interesting and thought-provoking. And I think we're all going to take away from these things how we can continue to improve.
Thank you.
Forwards. Thank you very much. Next, we have Krishna Gohil, who's going to talk about the National Wound Care Strategy Programme, Acute Foot Care for All and Models of Implementation. Apologies. Krishna is the clinical lead in lower limb for the National Wound Care Strategy Programme. She's also a Fellow of Podiatric Medicine for the Royal College of Surgeons and Physicians of Glasgow, and an executive member of the Foot in Diabetes Committee UK, and a member of the Medicines Committee for the Royal College of Podiatry. Thank you very much, Krishna.
Thank you, Richard, for that introduction as well. And thank you for the opportunity to be here and just to give you an update on some of the work that we have been doing as part of the National Wound Care Strategy Programme. So, as most of you may know, or some who may not know, as a programme, we have been funded to improve the delivery of care for 3 areas of wound care. So that's surgical, lower limb and pressure ulcers. And as you can see by these figures, the numbers with wounds and the cost associated in managing them is really, really huge. Now, the reason we are in this position, and the main reason for the increasing burden of wound, is the unwarranted variation. So too few people are receiving evidence-based care. Instead, there is often an over-reliance on dressing products, which often manage the symptoms of the wounds, but do not treat the underlying disease process. And all too often, wound care is poorly organised, which means there are significant delays in people being able to access care from clinicians with the appropriate skills and knowledge to accurately diagnose and treat the underlying cause of the ulcer. The system is not set up to make it easy for the patient or for the clinician either. And finally, very few organisations have systems which support them to accurately capture clinical wound care data and information. So many are blind to the scale of their local problem. Of course, that data is pivotal to both informing and sustaining quality improvement. So we set out to reduce this unnecessary variation in lower limb care, making better use of healthcare resources and improving outcomes for patients, and equally job satisfaction for our colleagues across the system. So we know that foot ulceration is a major precursor to amputation, particularly when it's complicated by ischemia and wound infection. And we know from the data there are almost equal numbers of ulceration in both those who've got diabetes and those who do not, and with the group without diabetes also accounting for a higher number of major amputations. What we do know is that there are really quite well-established pathways and services for people with foot ulceration and diabetes. And we also know that the healthcare needs for both groups are quite similar, but those people without diabetes find it very difficult to access the care that they actually need. So you will recall that the first thing we did as a programme was to identify the evidence-based recommendations for care. So they set out clinically what good looks like, and they seek to build on and address gaps in existing guidance. And the main highlights, therefore, are for the foot, bringing the pathways for patients with foot ulceration and without diabetes in line with those for patients with diabetes. And for leg ulcers, starting patients with some kind of mild compression in the absence of red flags, ensuring that they get their comprehensive assessment done within 14 days. We also developed a business case describing this case for change and quantifying the benefits of doing so. So there are changes. These are the changes we set out to do. And what we believe the framework is for improving lower limb care is made up of 3 main elements: people, process, and technology. With people, we knew we needed to outline a standard for wound care skills and knowledge and provide high quality education to a multi-professional audience and resources for patients and carers to educate, empower and support supported self-management. In terms of process, we knew that not only did we need evidence-based recommendations for lower limb wounds, but we needed to recommend completely reorganising the way in which that care is delivered. And this needs to be done in services staffed by clinicians with the appropriate knowledge, skill, and more importantly, the time. And finally, technology. We need to support clinical care and quality improvement through effective data capture and reporting, and work towards having an agreed set of national metrics to inform and sustain that quality improvement. So with the clinical recommendations and the fundamental principles in place, the programme progressed to implementation phase. And of course, writing recommendations is relatively the easy part, but actually implementing them in practice is where the real challenge lies. But if it was easy, then it would have already been done. So we recruited 7 first implementation sites, which we lovingly call FIMPs, to implement these recommendations, putting them and our resources into practice. And they are helping us test the assumptions of our implementation business case. And as a learning programme, we are observing how they implement our recommendations and resources and what approaches they are taking. We are working together to understand what the enablers are, what the challenges are, where the barriers are, where the gaps lie, and are so trying to resolve these challenges together. Because simply writing recommendations and saying things need to be done differently doesn't necessarily lead to change. Tools do not solve problems, people solve problems. So in 2021, we published a National Wound Care Core Capability Framework for multi-professionals, which is split up over 5 domains, 12 capabilities over 3 tiers. This framework sets a consistent standard of wound care knowledge and skills across the workforce. And we want this capability framework to be utilised locally to identify any gaps in knowledge and skill, which can then inform the learning and development plan for the workforce. It is important to note that the tier levels are not based on banding, but on how much wound care is part of their role. And to support this framework further, we've developed a suite of wound care resources which are free to access on the e-learning platform. And the statistics show that from the e-learning health team that there is good access to these modules. Although most of the access to the modules is by nurses and students, but for AHPs and more specifically podiatry, those numbers are relatively low. And we understand that education is a key part of the clinical pathway that we've developed. And here we have mapped the capability tiers required by the workforce at each of the clinical parts of the clinical pathway. And the new updated recommendations are going to be set out within these different parts. So since the commencement of the sites in April 21, our learning to date has been perhaps unsurprisingly that in practice, recommendations are both interpreted and delivered differently. This can lead to continued unwarranted variation despite good intention. And I'm sure this is the case for many guidelines produced and is a symptom of the way in which our existing healthcare services are structured, often working in silos. Research, local context, practitioner experience, and stakeholder preferences, values, and level of buy-in often influence the decisions made. And as a result, additional national work has begun to refine our lower limb recommendations and to shape the recommendation service delivery models that we're implementing, moving them from what needs to happen to how they can happen. So each part of the pathway, we have identified the aim and what is needed to achieve this. So for identification and immediate necessary care, what we're looking to do at this point is to reduce the variation in that timely access for anyone with foot ulceration and making sure that they're getting to the appropriate clinical team. So in order to establish this, we've identified that we need to make sure that there is the adequate training within the workforce so that individuals treating these foot ulcers have that skills and knowledge. We've also know that there needs to be clear pathways, not only referrals into services, but those referrals going on and up into escalated care. For assessment and diagnosis, we want to make sure that each individual 100% of individuals receive a documented comprehensive lower limb assessment and treatment and plan this in a timely manner. And again, we know in order to actually achieve this, we need to make sure that foot ulcer services are set up to accept these referrals, that there is the adequate time to care and do these comprehensive assessments, and that there is the equipment available. So one of the barriers that we have had is that, you know, taking toe pressures, individual places have Dopplers, but they don't then have the add-on equipment in order to achieve this. For ongoing care, we want to make sure that there is regular ongoing care for anyone who has got foot ulceration. And again, it's really clear we are dealing with the same thing, with need for clear clinical pathways, access to equipment, making sure the staff have the appropriate time to treat, have got the knowledge and skills in order to do so. And again, the review of healing, we want to make sure that the 100% of individuals get that review to make sure that the treatment plan that has been put in place is actually working. And if anything needs to be changed, it's done earlier rather than later. And again, the things we need to do to establish this is quite similar. And again, care following healing, we want to reduce that risk of reulceration. And we know that we need to tailor make these the care plans for each individual. We need to make sure that they've got easy access back into services should they reulcerate, and have got the advice on how to maintain their healed status going forward. So if I come back to the framework I spoke about earlier, we know about the what, and the FIMS have been helping us understand the how. So what we've learned so far from our first implementation sites in terms of education is that they're taking a blended approach to training. So they're combining online training with face-to-face delivery. And they're doing this right across the workforce, not just in silo areas, but across the whole workforce, with anyone who has got wound care as part of their job roles. And they are reporting that the online learning resources we've produced in conjunction with Health Education England are proving useful building blocks to complement local practical education sessions. They're a good foundation prior to attending taught sessions or developmental practical sessions via experiential learning. They've told us that the National Wound Care Capability Framework, sorry, it's a mouthful, is a useful tool in mapping the required and existing capabilities of the workforce. The challenges, however, have been that there is variability in how the Wound Care Capability Framework has been applied locally, and also in the approaches to experiential learning. Whilst areas have found the resources helpful, there is a continued struggle in practice to get ring-fence time for education, whether that be planning, delivering, or attending it. You know, wound care is often seen as a low priority, and so local approval to get wound care education resources is not really seen as essential and therefore can be difficult. We've reflected that there is a need to explore how to go about educating the workforce. And based on feedback we've received to date, we are currently further developing the capability framework to signpost more clearly the how to and where to access the resources to develop knowledge and skills at each of the tier levels. The additional good news is that with persistence, the importance of wound care education is being recognised, and some of our sites have now managed to get our online resources made essential or mandatory within their organisations. And we will be publishing example case studies of how they've actually managed to do this very soon. What we have learned in terms of revising pathways and processes is that despite a pandemic and large vacancies and pressure across the health system, the FIMS have managed to progress implementing the recommendation, but of course it takes time. All the FIMPs have managed to either expand existing dedicated services or reorganise their existing services to provide a dedicated service for leg wounds. This process, however, is taking longer for organising foot pathways. They've established protected time to deliver the appropriate care. And we all know that if you get the people to the right place quickly, who have got the right skills and knowledge and time, we do get those better outcomes. We also know that having specialist clinical leadership and oversight is also pivotal to ensure the appropriate level of support to the workforce and to ensure that quality care is maintained at all times. Of course, the local way and circumstances have shaped how FIMPs have approached implementing the recommendations. So historical commissioning arrangements mean some negotiation is needed with all the right stakeholders in the room. Because in the way that services are currently set up, we haven't thought about the population. We might have just set up a service for ambulatory population as an example, but brought about the homebound population and inpatients. We might have a good area of good practice in one part of the city, but not the remainder. We need to really think about improving working as a system. And we're aware that there are issues in relation to onward referrals to our vascular colleagues in terms of who to refer and the acceptance of these referrals. And we've been working on improving this timely and appropriate referrals to vascular service, and have developed example referral templates for PAD and CLTI and venous disease. And based on feedback, these have had some additional tweaks and they can be found on our website. And again, we've been working closely with the vascular services in our implementation sites to agree pathways, local pathways and processes. And obviously it's important to document that care that has been planned and delivered, and to do that effectively to support continuity of care. The only way to do that, we think really, is digitally, and having good templates and solutions to make clinical pathways work. Ideally, we think the best done with a wound management digital system, and we've got examples of these on our website. We know that the quality of data, if you get it, is poor, but we need to use this data to improve data. And data often raises more questions than it does answer. Again, that is good. It prompts you to go and dig a little deeper and improve. And we know that improving data capture and quality and effective information sharing is key to improving care and services. Because if you can't measure what we are doing, we can't see where there is unwarranted variation and help and support clinical practice and delivery. However, there is no recognised standard for generic information record that can support the delivery of wound care. And of course, we continue to have problems with the various systems not being able to talk to each other, including these wound management digital systems. So gathering data to demonstrate quality improvement and assist the sustainability of services still remains to be a challenge. And the level of digital maturity locally really affects the ability to track this data. And so as a programme, we are currently developing draft to address these challenges that I've mentioned. Is firstly, we're currently developing a draft business cases. Now there's going to be two, one for the establishing of leg ulcer services and one that is for foot ulcer services. We know that there is resource issues, and the ways to address this inequality of care for people with foot ulcers is either to A, expand the service, so we're not diluting that already excellent care being delivered for those who have got diabetes, or redesign the existing workforce. Now, this business case will be a draft that anyone can take away and adapt to make the case to address this inequality. The learning from all these sites is being used to enhance our resources, and we're now at the stage where we're developing best practice bundles. These will be separate documents for leg and for foot, and they will incorporate clinical recommendations and interventions with implementation advice and process outcome indicators. Alongside this, there will be supporting resources to assist local implementation to establish for ulcer services for all. Currently, the clinical recommendations are being updated. Again, these were originally published as one, but we have separated them to leg and for foot, but they will be published as a suite of recommendations, and these are due to be published at the end of May, and we will be having webinars throughout June to help clinicians support them in the implementation and understanding of them. We are also working with the professional record standards bodies to produce the information standard to support the recording of wound care data and information in the same way across services. So we think that will help with the way we collect data for wound care in general. So despite the challenges, our early results from the 7 sites are supporting the predictions of our implementation case, suggesting that it can be done. As the benefits of improving wound care are becoming more obvious though, our FIMS is stating to have a high profile with other healthcare provider organisations and also healthcare policymakers. And so this creates an opportunity for the national programme, the FIMS, and wider stakeholders to collectively tackle the challenges together and make a difference. And we haven't quite cracked it yet, but that's okay. But by understanding what helps and hinders clinical practice, we can take steps to try and address so that the changes we aspire to achieve are more achievable and sustainable. This is a system issue, not merely a practitioner one. So we're continually working with our sites to observe, learn and enhance our strategy. The Academic Health Science Network are providing implementation and change management support to some additional sites to implement the recommendations further. And as we move into the landscape of integrated care systems, we are hopeful that this will support the National Wound Care Strategy Programme's vision of delivering wound care services and solutions that move seamlessly between acute, primary and community care providers, working more collaboratively to ensure that patients get the right care at the right time from the right service, will not only improve wound care and outcomes, but support practitioners to deliver high quality care, ensure better use of resources and provide improved job satisfaction. If anyone is interested in becoming a stakeholder, then please go to our website. I've shared our website address there. We've also got a Twitter page and a LinkedIn page as well. And if you do have any questions at all, please do use the email to email in any questions going forward. All the resources I've talked about today are all available on our website, including example case studies, clinical metrics, and links to where the education is. So thank you for your time and happy to take any questions.
Thank you very much, Krishna. It looks like we've got a whole new world to explore with this group. We've had a question about dressings, and will there be recommendings regarding dressings, as we know that randomized controlled trials in this area are quite limited?
Again, we're basing all our recommendations on evidence, and because that evidence is not conclusive, we have done we can't recommend certain dressings over other dressings because the evidence out there is weak. So we have done a choosing dressings module on the e-learning, which goes into more detail about dressing choices. But we've also done an educational piece, which is about understanding the evidence behind these choosing dressings and the education. So how to understand what the quality of the research that you're reading to make an informed decision as to whether the outcomes of that study, whether you can take the quality of it to help individuals make that decision for themselves. So we have got that, and that's also on our website as well.
That's great. And then a question from Sarah Hart: will there be recommendations pathways for both inpatients and outpatients and community?
best practice bundles will be looking at all those clinical pathways. So that should address or help support individuals who want to create those pathways within inpatients and outpatients. That should help support them.
Yeah. And a question, why have recommendations been separated for leg and foot? Is it not more holistic to consider care to be lower limb?
Absolutely. We all, originally the recommendations were together. And from our implementation site, we found that people concentrated on one part of the recommendations and the foot was actually becoming forgotten. So by splitting them, we're giving the limelight, so to speak, to both leg and for foot, but there is correlation between the two. And even though I've said we've separated out the recommendations, they will still be a suite of one recommendations, which will include the foot and leg, and there is crossover between the two. So it'll still be holistic.
Yes. There are a couple of other questions, but we're running short of time. So thank you very much, Commissioner. I'll leave it there.
Okay, no worries. Thank you.
Thank you. And we will have a break for 10 minutes, quick comfort break, and we'll start back at 25 to 3. So I shall see you then. Hello and welcome back to our second session. During this session, there's going to start with a panel discussion. This House believes that all foot attacks should be managed by a vascular surgeon. And our panel of speakers, Ben Yates. Ben's a consultant podiatric surgeon at Great Western Hospital's NHS Foundation Trust. Also Keith Jones. Keith is a consultant vascular surgeon at Frimley Health NHS Foundation Trust. And I'm going to hand the chair over to Debbie Sharman, who's consultant podiatrist, diabetes and professional lead for podiatry at Dorset Healthcare University NHS Foundation Trust. Thank you, Debbie.
Thank you, Richard. Good afternoon, everybody. Welcome back after the short break. So I hope we've got quite a lively and interesting discussion and debate for you this afternoon. Richard has just introduced our two guest speakers from each side this afternoon, and we're going to start off with a quick poll via Slido, which I'd like you to all participate in. In the chat, you will see a link to the Slido poll, and I'd be really grateful if you could all please just go to that, click on the poll and answer the question as to whether or not you agree with the statement that this House believes that all foot attacks should be managed by a vascular surgeon. So just click on the agree or disagree. Thank you. Okay, and we should get the results of that through fairly quickly. And actually, we've got an overwhelming response here. 75% disagree with that statement and 25% agree. So at the moment, Mr. Jones, you've got your work cut out, but I'm sure over the course of the next few minutes, you will do your best to switch those round. So without further ado, I'm going to hand over to Mr. Keith Jones, consultant vascular surgeon. You have 8 minutes to present your case, and I will be quite strict with the time, and I will let you know when your 8 minutes are up. Would you like a 1 minute warning, Mr. Jones?
Yeah, that's fine. I don't think I'll need it.
Okay, super. So without further ado, I'm going to hand over to you, and then following on from that will be Mr. Yates. So keep it clean, please, gentlemen, and over to you.
Okay, well, thank you very much. I can see that you'll get to have a lovely view of my ceiling here. I'm delighted to represent vascular surgery in this debate. I thought I was actually going to be someone's wingman rather than be the primary presenter, and so I'm going to do this without slides, but with a clear knowledge of all the details. I have to say, my first disclaimer is that I don't actually believe the statement of a panel discussion, because I think we should have added in the additional as part of an MDT, because ultimately I think that vascular surgery should lead the management of the diabetic foot MDT, because someone needs to lead it, because it is a real requirement for it to be delivered in the acute setting, and we are the acute surgical specialty with clear access to all the acute resource, and so therefore we are best placed to do this. And that's whether or not it's through our acute on-call structure, whether or not it's through our hot clinics, or through our involvement with the multidisciplinary clinic diabetic foot MDTs and clinics, both in person and remotely, when dealing with the issue of spoke sites. So someone needs to coordinate this process for the management of foot attack. The presentation, recognition and pathway needs to be as quick as possible, and we have the structure to do that. Now, those units in the country where this has been led, and they have well publicised, documented units where vascular surgery has generated a large amount of evidence. Two examples would be Leicester and Manchester, where the pathway is followed, and they have published very clear improvement in the care of diabetic foot, reduction in major limb amputations, and a more rapid pathway. Now that it always, however, involves a very strong MDT environment. Vascular surgery's got a very strong structure of MDT working, and therefore is very easily resourced to be the lead in this environment. Now, the management of the complex diabetic foot and the acute presentation of the diabetic foot is one of only 3 mandated critical conditions within the vascular surgery curriculum. It's that important to vascular surgeons. We are the only GMC agreed surgical curriculum to specifically highlight and outline diabetic foot management within our curriculum and syllabus. So we are the surgical specialty which has always taken the lead, and therefore I think we should be managing the foot attack. The pathway always seems to break down when it is not a vascular surgeon being involved. Now, you might say, what about the spoke hospitals? Well, we can provide remote leadership. The importance it is to utilise the MDT structure to recognise the acute and hot diabetic foot and get that transferred in as rapidly as possible, so that they can be managed and dealt with by the vascular surgery team, which will have the most rapid access to the acute theatre environment as necessary. We are active participants with all multiple MDTs, be it with our radiology colleagues, with yourselves within all aspects of the foot network, being that podiatry, podiatric surgery, and orthopaedic surgery, and the specialist diabetic nurses and the diabetes practitioners. So these links, and add that to our advanced vascular surgical network as highlighted by the provision of vascular surgery documents, which, to say as an aside, highlights very clearly the importance of the management of the foot attack as the hot diabetic emergency. And therefore, we do have the structure And that is what the important aspect is someone needs to provide the overall structure and coordination of the management of the multidisciplinary foot environment to allow patients to get intervention as quick as possible. And for a large portion of those, that means acute surgical debridement. And acute surgical debridement it is best delivered by vascular surgery, which is, I'd say, the only surgical curriculum where this is on the fully documented within the syllabus, and it is a mandated condition for certification. So you can't be a consultant vascular surgeon in the UK unless you have expertly demonstrated your ability to manage the acute hot diabetic foot. Now, I'm sure that my co-debater will provide reasoned arguments about why podiatric surgery would be a better option, or why there may be other better options of being managed ultimately by vascular surgery. But you can't argue against the structure and the availability of the acute network that vascular surgery provides, and the fact that diabetic foot management is so integrated into our pathways of care, the provision of vascular surgery documents, and our curriculum. Now, I did look, and I see Ben's background of having worked from La Trobe, that well-known artistic university in Melbourne. So no doubt he will paint a very flowery picture of why perhaps diabetes foot attacks should be managed, or indeed all foot attacks should be managed by others than vascular surgery. But it's simply not true. It's all that, it's a flowery picture. The truth and the evidence related by the curriculum, the provision of vascular surgery document, and the validation given to both those by the GMC is
1 minute, Mr. Jones.
I don't need it. I merely say that it should therefore be managed by vascular surgery. I hope I've made my case.
Thank you very much. Very eloquently put. And with that, I shall hand over to Mr. Yates, who is going to present us with the counter argument. Over to you.
Thanks
8
very
minutes.
Okay, thanks very much, Debbie. I'm not sure I need to say very much after Keith's already admitted that he doesn't believe that vascular surgeons should be leading the foot attack service, but I'll try and elaborate and give some reasons as to why I think that's that shouldn't be the case. I without doubt agree that, as I'm sure we all do, that acute diabetic foot management is best managed by a multidisciplinary team, which should obviously include access and input of vascular surgery. So I work at the Great Western Hospital, which is an acute sector. So we work within an acute service, so we have all the access to acute facilities that my vascular surgery colleagues have. And our services at the Great Western Hospital, we're a fairly large DDH. We have about a 400,000 population that we service. About 7 to 9.5% of the population have diabetes. And we're a vascular spoke service. And I think that's probably crucial to the argument that I'm going to be putting forward, in the fact that I personally don't believe that vascular surgeons should lead the acute diabetic foot service at a spoke hospital, because they're just not there sufficiently in order to provide that type of service. So our service, we have weekly MDT, diabetic foot ward rounds, dedicated referral pathways, dedicated hot foot clinics. We have vascular podiatric surgery clinics. We have a monthly MDT clinic. We have 2 diabetes podiatrists who are diabetic foot coordinators, and I'll come on more about that role, because to my mind, they should be the gatekeepers of the hot foot or the acute diabetic foot clinic. That decision as to whether patients should be admitted or not. Just as a potentially further evidence, what we did is that we've just reviewed our foot attack referrals and outcomes over this last year. And of those referrals, only 16% had a diagnosis of peripheral arterial disease. and only 11% of patients who came to that foot attack clinic actually required revascularization surgery by the vascular team, and only 1% required an amputation by the vascular team. So the majority of the surgery where it was indicated was provided by the podiatric surgical team. The way that we try to structure our team is that we have the diabetic foot coordinator, and the purpose of that coordination is to organise the investigations and interventions and assessment by all of the team members that you can see there within that panel. So the endocrinologists, the diabetes podiatrists, TBNs, OPAT nurses, etc., diabetes nurses. And from a surgical point of view, podiatric surgery does by far the vast majority of the surgical procedures, which I'll come on to in a moment. Limited orthopedic input, and vascular and interventional radiology, as you've just seen, has a fairly limited input in terms of the overall numbers, but obviously plays a crucial part to the management of these patients where indicated. So this is our current surgical service. We have virtually 2 whole-time equivalent podiatric surgeons. We have dedicated weekly theatre sessions for acute diabetic foot surgery. We use emergency and trauma theatres where we need to. We have interventional radiologists who undertake an angioplasty list, and all other vascular surgery patients are transferred to the vascular hub for more significant vascular interventions. When we think about types of diabetic surgery, we tend to use the class 1, 2, 3 and 4 levels that were popularised in the 2006 International Framework for Management of the Diabetic Foot. And of that class 3 and class 4, that's the ones that we mainly talk about really when we're thinking about the diabetic hot foot patients. So the majority of these patients are going to end up, if they're going to have surgical intervention, with some form of amputation, but it may be debridements, INDs, Charcot reconstructions, calcanectomies. And I would argue that podiatric surgery is a much better place to undertake these types of procedures than our vascular surgical colleagues. So we do approximately 120 cases a year of emergent curative surgery. Our length of stay, I've been in post for 20 years. When I first came here, our length of stay for diabetic foot patients was 35 days. And we've now reduced that down to 10 days with medically fit for discharge at 6.4 days, which is way below the national average. We're below average for major amputations. We're in the top 15% for length of stay and ulceration healing, and also hospital readmissions under our GIRF data from 2019. And that's all improved in this last 2 to 3 years, particularly during the COVID pandemic, in terms of length of stay. So just a couple of cases just at the end. This is a calcanectomy patient, or drill and fill as we now tend to do, but this patient's got calcaneal osteomyelitis, single vessel runoff, and a significant stenosis in the lower limb vessels, and they were traditionally would have been treated with a baloney amputation, but this is the type of thing that we do routinely, and this patient underwent drill and fill. You can see that's the MRI scan of her osteomyelitis. So this is just the debridement, excision of all necrotic tissue, insertion of antibiotic bone cement, which is something which we tend to do, and I don't think many vascular surgeons do. And she went on to heal. That's her at 8 weeks, and she went on to heal, and she's kept her leg. And I think the majority of my vascular surgery colleagues would have not done this type of procedure and would have chosen more to do a baloney amputation if they were going to offer any type of surgical intervention. So I think, to our mind, we run a very good service. I appreciate that not all acute services have podiatric surgery on site, but there are many good examples of community-based podiatric surgery offering very good, appropriate management for classes 1, 2, 3 and 4 diabetic foot cases. And I think we, in conjunction with diabetes podiatrists, diabetic coordinators, should be the ones leading hot foot clinics to determine the best outcome for patients with acute diabetic foot disease. Thank you.
Thank you, Mr. Yates. You have a minute to spare there. So before I come back to the points there, I'm going to offer Mr. Jones a couple of minutes to come back, having heard what Mr. Yates has had to say. Anything you would like to come back with there, Mr. Jones?
I would like to congratulate Ben on the excellent management that he provides for their patient population in their spoke hospital, and that's the relevant factor. It's they're working in a spoke hospital, which is part of a larger network. So I sit here on call for vascular surgery in a vascular hub. My patient population is 1.6 million. I have 4 spoke hospitals, each of which are facilitated by exactly the same numbers of MDT clinics and podiatrists as Ben describes, and all have a degree of localized acute provision. But for the majority, we would be transferring to the vascular hub unless in one circumstance where one of our orthopedic colleagues provides the foot and ankle service very similar to that Ben describes. The question raised was whether this house believes that all foot attacks should be managed by a vascular surgeon. If you're talking about who has the facility to manage all, it is only vascular surgery. There isn't a provision nationally for podiatric surgery or any other group to manage the foot attack in the way that vascular surgery can. The fact that it should be managed by vascular surgery, that is very much in a leadership role and one that of coordination. It is very much a multidisciplinary provision of service, and that should be highlighted. We have a lot of people with a lot of skills, very well demonstrated by the case that Ben showed there in the utilisation of what I assume was CERAMET and the drilling of a calconectomy, which we provide as very much standard practice as part of our network. It's coordinated by us as vascular surgery. It isn't necessarily always done by us, you're very right, as vascular surgeons. But whether or not all foot attacks should be managed by a single group, the only group possible to do that is vascular surgery. That's my case.
Thank you very much, Mr. Jones, and Mr. Yates. In the interest of fairness, I'm going to give you the opportunity to come back there.
I think both Keith and I actually probably agree. I think that in the fact that, to my mind, acute services, they're very much, there is a process in terms of how they should be managed, but often it's down to individuals who have the skill and dedication and desire to run these types of services, and that's usually what's going to provide the best service for patients. And it's ensuring that they're appropriately managed in that MDT, pulling in people that are required. As to who should coordinate that care, I think that it's difficult to argue that it has to be one particular profession. I don't personally believe it has to be one particular profession. I think it could be any number of professions, as long as they've got the appropriate knowledge and skill set and ability to liaise and manage patients with the various different specialties to hand.
Excellent. Well, thank you both for both those viewpoints there. Mr. Jones, you have a hand raised.
I did. I just wanted to make the point that to those that hadn't noticed that Ben clearly recognises the importance of the circulation in the management, since he has a cartoon of the cardiac supply on the whiteboard behind his head, and therefore he clearly deferring to vascular at that time. Thank you.
That wasn't actually my drawing. I share an office with a foot and ankle orthopedic surgeon, and that's his rudimentary understanding of the heart. So,
gentlemen, thank you. Now, we're going to open up to the floor for some questions to you both. I can see that we have got some in the chat. So first question, do both of you have a dedicated joint MDT review approach to inpatient care of individuals presenting with an acute hot diabetes foot complication? Or are patients reviewed by members of the MDT separately? Mr. Jones, I'm going to come to you first.
Yes, we do, and we do that on all of our spoke sites as well. Because of the multiplicity of the numbers of surgeons we have on our rota at differing days of the weeks with different surgeons visiting, and they can take part in the acute MDT working on those spoke sites. And on the hub site, there is very much a defined inpatient management MDT coordinated with a vascular surgeon, a diabetologist, a foot and ankle surgeon, and tube podiatrist, and the vascular nurse specialist.
Thank you. Mr. Yates.
Yeah, I mean, it's interesting actually. When I first started, so this is 20 years ago, we didn't basically, you know, I used to be pink slipped as my vascular surgery colleague did, and you'd go off and see the patient by yourself, and you know, you'd write in the notes what you thought should happen. And we changed that about 15 years ago. So we've had an MDT inpatient rounds, which we do twice a week. And that has ourselves, diabetes podiatrist, vascular input, endocrinology, and we have an antibiotic pharmacist and microbiologist who also come in on that rounds. So yes.
Thank you. We've got a couple of comments as opposed to questions, but may elicit some comment from you. One is around the joint MDT, which I think we've probably just covered in that previous question. Commented, delays in transfer to the hub from the spoke in our area means that the medical team actually manage these patients. What are your thoughts on that, gentlemen? Mr. Jones first.
Yeah, and I recognise that that is an issue that has been described. We try to get around that, as I say, by providing greater on-site spoke working. So all the within the job plans of all the surgeons, 30% of their time will be spent in the spoke. And therefore we have multiple surgeons provided at the spokes. We have a lot more on-site spoke access. And so we try to diminish the delay in theatre on those occasions, and so they'll be taken acutely to theatre on the spoke sites. And the issue in delay to management much more relates to the time to revascularization. So if you didn't know, there is a national sequin ongoing whereby vascular surgeons should be revascularizing patients presenting with critical limb-threatening ischemia within 5 days with admission to hospital. So the imagine was that they would have debridement of their foot attack, and if there's a vascular component, then their revascularization event should occur within 5 days. And if the vascular surgeons with their interventional radiology colleagues don't make that, in 60% of cases, then a component percentage of the whole acute payment to a trust is taken away. So there's a real drive for vascular surgery to be able to do that.
Thank you, Mr. Yates.
Yeah, it is an issue. I think we do have an issue in terms of getting patients off to the hub, and I think also actually probably a slightly bigger issue in terms of repatriation afterwards. We have had quite a few situations where patients have been kind of discharged from the hub and they've sort of been lost to follow up, and So there are some issues related to that hub and spoke in terms of step up and step down transfer of patients. But certainly in terms of the acute need for emergency amputation, etc., then generally that's worked really well. But it's probably for the more ongoing, where someone's had a revascularization and maybe a debridement, and they've kind of been lost to appropriate follow-up, having had that at the hub, not necessarily coming back to the spoke as they should do for their ongoing management. So,
and I think that's an issue in many areas, isn't it? There's a comment, another comment from Dr. Richard Paisley, about hubs having gradually withdrawn presence at spokes with delayed access for some foot attacks where revascularization could help, resulting in increase in major amputations in that group. There a question from me, and I would invite our audience to please put any further questions in the Q&A so that I can raise those on your behalf. So we mentioned their admission and whether patients come in under medicine or surgery, and interested to hear your thoughts regarding how the sort of pathway is set up to make that clear. I'm thinking, perhaps when say a GP or somebody working in the community, how are your pathways in your areas clear as to the route of admission for an acute foot attack, or does it really depend on who knows who? Mr. Jones.
Thanks very much for the question. Very topical, because we have just been in recent times opened up both the hubs and the spokes to direct or far more direct community podiatry admissions. And so we've taken the GP out of the loop as an unnecessary step, and primary care within medicine, we're very keen for that as well. And so that's working. And I think that therefore is beneficial. I think the important aspect is the speed of which a recognition and referral is made. And so to my mind, it's really important that there is a very available network of community podiatry as the front door, because actually that seems to get patients triaged and brought in much more appropriately and more quickly. Certainly, I think it's a much better route than patients self-selecting to A&E, where unfortunately sometimes physicians outside of the specialists that are speaking today seem to feel that they have a better idea about how they should be managing it, because everyone seems to be supposed to be discharged from A&E. They're blocked from the service. So I think it is a much better route by utilising fast track pathways involving established members of an MDT structure. And it's really important that we highlight that to GP. So I'd like to see a reverse of the pathways of patients having to be referred from podiatry to their GP in order to get into a hospital network. That the GP should be referring them to podiatry, because podiatry has the access door into the acute foot network, or rather than redirecting, so they're not seeing a GP at all, and they're going straight through the acute foot network, and leaving themselves to get the appropriate debridement of their acute foot attack presentation, be that whoever's doing that in the spoke or in the hub.
Thank you for that, Mr. Yates.
Yeah, I think it's obviously crucial that there are appropriate pathways which are recognised by all the people, all the stakeholders, so that they can follow those pathways directly. I think the question was more in terms of who should manage the patient medically when they're in hospital. So who should have, was that the question?
Well, so there is, there's often debate, isn't there? You know, when the patient reaches the front door, are they admitted under the medics or are they admitted under the surgeons? And there's almost this sort of bit of political, you know, sort of toing and froing as to where the patient should sit.
Yeah, absolutely, and you're right, and I think there is, and I think certainly in our experience, patients are generally the acute diabetic foot cases are generally much better managed on the medical wards, because they tend to have significant medical issues associated with their diabetes control, their renal function, etc. Obviously, they're likely to have infection. I think the infection management, as long as you follow the pathway, is probably the same, whether they're on a medical ward or whether they're on a surgical ward. Most trusts have, you know, antibiotic guidelines that they tend to follow for acute diabetic foot cases. So that those are fairly standard, as long as the appropriate staff know on those wards the guidelines that they should be following. I don't think that's necessarily too big an issue. I guess you could argue that the wound aspect may be better managed by the surgical team. I think probably post-operative pain is generally managed better by a surgical ward than it is by a medical ward. So I think in many ways it should be probably what is the main factor driving that admission. If you've got a diabetic patient who is severely out of glycemic control, yes, they've got an infection. To my mind, they're better managed on a medical ward under endocrinology than they are under an orthopedic ward, which is our alternative. We don't have our own podiatric surgical ward. Our patients are admitted either through orthopedic, co-admitted either with orthopedics or with endocrinology. So that's kind of the way that we tend to steer patients.
Thank you for that. Anything else to add to that, Mr. Jones?
No. I think that's all very reasonable indeed. The most important thing is that we're involving the whole multidisciplinary care package, and it's clearly well signposted within whichever trust you're working in. It's, as we know, driven by interested parties and people that were enthusiastic to the cause, so to speak. So there will obviously be some variations overall. My point back to the original question is that if one person needs to lead it, that the only person people needs to lead the whole management package would be vascular surgery, but they could do that very much guided by the steering hand, be that of podiatry or diabetes.
Thank you both for that. So we've got another question here about how would the vascular or any surgical team address those not attending secondary care sites? The medics can do virtual reviews and work with community and primary care. So I'm guessing that's perhaps a question about how to reach those that aren't necessarily attending the hospital sites, and I think maybe part of the answer there lies in sort of referral from the community podiatrist, but I'll give you both the opportunity to comment on that. Mr. Jones.
Well, as I mentioned, we've recognised the importance of the referral pathway between community podiatry directly into the service, and so I would highlight that as the remote working aspect that we're able to do. It's through the development of tech, and I've got many colleagues that have utilised sort of local picture and pixelated technology of measurement of wound sizes, development of wound, change of wounds, and comparison software. We've just got a new system in our trust of Epic, which allows us to have much more pictures and wound representation on it. So it allows us to give opinions over wounds from a remote site that can be delivered by the acute service at the hub out of hours as well. So my answer is I think it's surgery is well able to give opinion and intervention on remote wounds, but it's by the utilisation of developing tech. And I think it's really important that anyone that's using and finding good outcomes with any new technology highlights that to the bigger community.
I think that's a really good point. We're seeing lots of new ways of sharing that information. Mr. Yates.
Yeah, I would agree absolutely with what Keith's just said. I mean, certainly we started doing this more and more, particularly during the pandemic, when we had a lot of patients who didn't want to come up to the acute sector at all. And so we would have virtual reviews with the patients, you know, on FaceTime or Teams or whatever, with the district nurse or the podiatrist that was there actually with the patient. So we were assessing the wounds and the state of their foot and lower limb via video link, and giving an opinion as to whether or not or what, you know, giving an opinion in terms of their management. But I think the new software systems which are coming online now undoubtedly will be a significant advantage in terms of ongoing wound care management, particularly if they can be shared so that everybody has access to that type of imaging for each patient to monitor wound progress.
Thank you. And just having a look at a couple of other comments, certainly there we've got some podiatrists who do refer directly to vascular, and Dr. Paisley's comment about where this is in place, it's helped to reduce amputations in several provider areas in the southwest. Another comment that we need acute foot wards. I think we'd all like those. And another comment about doing virtual reviews in MDFT of housebound patients. So I just one last question for me, and then I'm going to sum up, and we'll then go to our final vote. We heard earlier this afternoon from Nicole and from Professor Game about the variation still across the country. And I noticed, Mr. Yates, only 16% of the population that you see have evidence of peripheral arterial disease, which could align with your lower amputation rates as well, because where there is a higher incidence of ischemia, we know the amputation rates are higher as well. So just a comment from you both regarding that, perhaps. I'll let you go first, Ben.
Sure. I'm sorry, I missed the earlier presentation. I've been operating, so I've just come out for this session. Yeah, I mean, I guess the point of there are multiple studies which have looked at the presence of peripheral arterial disease in diabetic populations, and I think the question is, the reason why I raised that is many people can you know, do APPIs, do toe pressure indices, etc. They can refer for duplexes and MRAs, etc., and therefore seek a vascular opinion based on the assessment. In our experience, and obviously, you know, a lot of the things that I do as a podiatric surgeon, many vascular surgeons do, undoubtedly. But we have obviously, you know, as podiatric surgeons, we have a very particular interest in the foot and how it works and the function of the foot post-operatively, which that understanding of biomechanics, I think, is far greater in podiatric surgery than it is in vascular surgery. So in terms of amputations and amputation management, etc., I think that's much better led by a podiatric surgeon. So yes, you know, we've published on our patients with calcaneal osteomyelitis and how many required a below-knee amputation and how many survived, and the survival rate with calcanectomies or partial calcanectomies and the presence of peripheral arterial disease. We did exactly the same with our transmetatarsal amputation study and data. So I think that the point I was trying to make is that although peripheral arterial disease, the prevalence is variable, the actual numbers that are requiring vascular intervention in terms of revascularization is often quite low as an absolute percentage population of those acute diabetic foot admissions.
Thank you. And final words to you, Mr. Jones.
Well, no, thank you. Well, 15% is the instance of asymptomatic peripheral vascular disease in the population of 70 and above. So, you know, those are quite representative figures, maybe, of a localized patient population. That percentage is generally much higher in the population that have diabetes mellitus. Now, I have never been fortunate enough to work in a trust in my several consultant appointments that had a consultant podiatric surgeon, and so all of that array of work that they have undertaken, I've sought to undertake myself. And since I wrote the vascular surgery curriculum, it was me that ensured that it was inserted in, because I thought it was much more likely that vascular surgeons should be managing and leading the foot attack and delivering that high level of perifoot amputation care, because it's not in the orthopedic curriculum, as I'm sure Ben knows, and therefore I think vascular surgery overall, country-wise, are best placed. There are going to be hotspots where the expertise that Ben provides are a very, very welcome adjunct, but he'll be the first to admit that he is not the common or garden grey squirrel. He's far more of the red squirrel variety, as a degree of rarity, whereas myself and the other greys need to be able to deliver management, and therefore that's why it's all in the vascular surgery curriculum. That's my point.
Gentlemen, thank you very much, and thank you both for a most respectful and eloquent this discussion and debate. So Mr. Jones believes that vascular surgeons are best placed to both coordinate the process and the pathway of the acute foot, and indeed have the structure to do so. So they have the best leadership to and capacity to manage. Mr. Yates has put forward an excellent counter argument as to the expertise that the podiatric surgeons can bring to the table, and both parties stressed that the most important thing is a multidisciplinary approach to the management of the acute diabetes foot. So we've come to the end of our time now, so we're now going to go to our final poll, and again ask the question to you all, and if the poll is in the chat, if you could go to that. So, do you believe that all foot attacks should be managed by a vascular surgeon? And if you could kindly enter your thoughts, and we'll see how things have changed from our first poll. Okay, and well, so this house believes that all foot attacks should be managed by a vascular surgeon, and with very similar results. We've got 26% agree and 74% disagree. Oh, I think that's changed slightly. 79% disagree, 21% agree. So not a lot has changed significantly, but I think what we can all take from this is actually that the best way to manage these patients is through the multidisciplinary team. And so on that note, I would like to thank both of our speakers, Mr. Yates and Mr. Jones, for your time this afternoon. Thank you very much.
Thank you.
Thank you. Have a good rest of the day.
Thank you all. Thank you to the panel. That was a very interesting discussion. I'm surprised that the results in the second round weren't swayed slightly differently, but there we are. We shall now move on, and we're going to listen to Hannah Baber talking about the role of the pharmacist in the multidisciplinary foot team. Hannah is consultant pharmacist for diabetes at the Leeds office of the West Yorkshire Integrated Care Board. She's also chair of the Diabetes Steering Group and Cardio-Renal Metabolic Expert Working Group for Leeds, and is also a member of the Committee of Healthcare Professionals at Diabetes UK. Thank you, Hannah.
Thank you very much. It's a pleasure to be here. So I'm just going to share my screen really quickly. So thank you for inviting me to talk about the role of the pharmacist within the multidisciplinary foot team. This is something that has come off the back of me moving to Leeds, and really an innovative piece of work that had started before I arrived. So I need to really give credit to both Keely Spencer-Jones and Nicola Butler, who are some of my senior pharmacists who have done an absolutely spectacular job of integrating into our multidisciplinary foot care team and making a real difference within. So we got some funding from Novo Nordisk to run this project, and really what we intended to do was do a scoping exercise really on where the pharmacist might fit. And I think, to be honest, the scoping exercise continues, and we're really excited to know kind of what the next steps are. So I'm going to paint that picture of kind of where we're at as a city, and kind of what our forward plan might look like. So the plan originally was that funding was initially requested with the intention of facilitating a 0.6 work time equivalent of pharmacists to attend what was already the well-established diabetes limb salvage clinic at Leeds teaching hospitals. And the funding would be used for backfill. And this time takes into account both clinic preparation, facilitation of patient follow-up and data collection thereafter. And why was it needed? So we knew that there was a large number of appointments in diabetes outpatient clinics, and these patients were often seen by that sort of plethora of healthcare professionals, both in primary and secondary care. But one thing that we'd really noticed was, despite all of this and despite lots of contacts with people, there was still lots of opportunities for medicines optimization specifically, and we wanted to know kind of why are those opportunities being missed, and would there be an opportunity there for pharmacists to get involved. And while we're there, were there things that we could help with within the team to kind of facilitate smoother running of the clinic, and take some of the burden of obviously, you know, what can be a very busy clinic environment. So are the people in clinics resistant to treatment? We wanted to know, and would there be less resistant in the foot clinic due to the severity of their disease as well? So sometimes you've got that avid audience, haven't you? Something pretty critical has occurred, and people are re-engaging with care at that time. So we did a baseline audit before we started the project, and of around 50 patients, and we found that roughly 62% of HbA1cs, 32% of blood pressures, 56% of lipid readings did still have scope to be optimized within the clinic. So like I say, we proposed to use that existing clinic to review those patients, and it's basically the 3 treatment targets. So is this backed up by evidence? Would it be useful? So obviously, although definitive guidelines exist, people with PAD continue to be undertreated in terms of medical management and risk factor modification. We know that. And the REACH registry showed that in outpatient settings, people with PAD alone versus those with PAD in addition to coronary artery disease or cerebrovascular disease were prescribed antiplatelets and statins less often often, and they felt that this was likely to be due to the ongoing perception that PAD wasn't as severe as CAD, and on this conversation's gone for years, isn't it? So it's specifically around kind of that cardiovascular management. We felt that there might be a particular focus on that might help us really close a gap. And Leeds has really signed up to management of multimorbidity and not doing things in silos. And we're working really hard to kind of make progress towards that, both in the model of care that we're designing as we go forward into our new integrated care board structures. And so what is population health management planning? So, so we're looking at kind of moving away from that organizational model, which I think has been discussed today in some of the other talks, and moving much more to that pathway model, and then moving on to this population-based model where we're starting to think about what's that person's flow, where do they need to be, and how do we facilitate that as best as we can in the right place. And we've also signed up to a 4-tier model of care for diabetes specifically, where we're looking to really drill down on these sort of 4 tiers of what we deliver in teaching hospitals at tier 4, our Leeds community hospitals at tier 3, delivering a primary care network diast model within tier 2 across primary care networks, and at tier 1 doing good basic care well. And clinical pharmacy specifically is a practice that's expanding in all 4 of those sectors. And actually, in addition to that, community pharmacy as well, which is that real, you know, neighbourhood hub for healthcare expertise that I don't feel has ever really been tapped into enough for what they might be able to deliver, and with regards to some of the good basic care mantra that we would all like to see. So I think, you know, clinical pharmacy is something that could give a real good tiered model and work to this tier model of care where we can really look to deliver to deliver the care where somebody could flow freely through the different sectors and get followed up appropriately. And what education and support we hope to deliver within that tier model for the pharmacist, but also for the whole healthcare team, is that train the trainer approach, where we're getting sort of the team with the more specialist knowledge to build up expertise within the tier below, so that we're doing the right thing at the right place. And this is this is from a paper on the left, just showing kind of how multimorbidity builds over years of practice, and then also of years of diagnosis, sorry. And obviously, you know, that picture of comorbidity really starts to build by the time that you get to 10 years. And you can see here, this is some data from the Leeds model that we're working on currently. And the PAD picture particularly is important with regards to kind of 3 long-term conditions. Once we get past the 3 long-term conditions, you're really seeing PAD to start to play a part. And we know that this is underdiagnosed. So these are only people who have a coded diagnosis as well. So this again is kind of 2 comorbidities, and again you can see the numbers are large, and how we kind of build within that a system of care that can deal with this great burden of multimorbidity. And what we've seen as well is we're looking at healthcare utilisation. So we know that in Leeds, there are 60 people in Leeds who have 6 cardiorenal metabolic conditions, including peripheral arterial disease, and they generate the most planned and unplanned healthcare activity in the city. So that's out of around 250,000 people who sit in our long-term condition population segment. So, and what we also know is that the average healthcare activity for these 60 people is that they have around 79 contacts with healthcare systems per year, which is just staggering to me, and I think staggering to the rest of the team when we've heard that. So we're in the process of unpicking that, but it just shows that actually there are high users of the system where we're not doing the best that we can. To have 79 appointments with people in a year for one reason or another is just no wonder people are overwhelmed by their conditions and unable to really move forward with good care. So we ran the clinic, we've been data collecting the whole time. We're still in the clinic at the moment, but when we'd done some of our interim data collection, we'd had 676 patients we reviewed in the year, and they'd been attending clinic, and the reviews for age, weight, BMI, smoking status, ACR, LFTs, renal function, HbA1c, blood pressure, lipids, and all relevant medications. And then the pharmacist would make recommendations based on what the results of that were at the time. And so what type of interventions have been made as a result of this clinic? So lots of different interventions and quite wide ranging. So from simple things like making sure that we've requested overdue bloods, including HbA1cs and lipids, discussing and advising on medications, including issues with side effects, adherence, counselling on new medications, that medication reconciliation and allergy status, sometimes that can be quite difficult to navigate. As we've already discussed, people are massively multiple morbid, and so they can be on 20 plus medicines with allergies that are difficult to kind of navigate around. Discussing and advising on smoking cessation, optimizing or initiating treatment for hypertension and lipids, and we'll talk a little bit more about that, and referring to innovative clinics that are set up that connect into some of the risk factor management. Providing that advice and follow-up. So like I've said, we're everywhere pharmacists, we're a plague really, and there is benefit to that we have good in-reach into lots of different sectors. So actually getting that follow-up done and being able to connect with other teams is really a selling point for ourselves. And antiplatelet reviews as well, advice on new medicines, side effects, and liaising, like I've said, with community pharmacies, so who often help with things like reminder charts, medi-doses, basic supplies, but also they have some advanced services which are already paid for, things like structured medication reviews, new medicines reviews. So if you've started a new medicine, they will follow up with that patient to make sure that they're managing it okay, give them a bit more information, go back through side effects, etc. It's quite good, especially when people are getting told a lot of information at any one time, and then pain management as well. So these are some of our data. So I think probably the most inroads that we made over the first 6 months was really around lipid management. And like I say, we're still in the process of doing data collect, so bear with me on this. We have really well-established lipid services within the teaching hospitals and within Leeds in general. And so because of that, it really showed how it facilitated having good systems of care across the healthcare system, how that really facilitates us being able to do a better job at the sort of the coal face, if you like. So there were lots of lipid optimization done, but there was also referrals made to the innovative pharmacist-led lipid clinics where patients could get appropriately started on injectable lipid therapies as they became able to go on to those, or relevant to go on to those. And I think that's something that's really important. And as that field grows of injectable lipid therapies, as we're seeing inclisiran come into play, that'll be a primary care injectable therapy. This becomes even more relevant. We need to be identifying and getting patients onto what may be life-saving medications for them. Blood pressure is a little bit less successful in the 6 months that we've looked, and most of that was to do with the fact that we did a good job of recognizing who needed help with their blood pressure and highlighting that downstream. But I think one of the barriers was that obviously the recommendation now is really that we don't go off a clinic blood pressure reading, and that really patients should be doing either home blood pressure readings or ambulatory blood pressure readings to make that decision as to whether they really need escalation of therapy. Obviously RAS blockade may be the exception to that, depending on whether somebody's got CKD or not. So I think there were some things that we still need to work through on the blood pressure front, and how we really tap into that primary care resource a lot better. So there's a big hypertension project about to commence in primary care, driven by the DES and some of the QOF outcomes. And so it's really important that we kind of get on that bandwagon to help these high risk patients. And HbA1c, I think part of this, again, is the fact that we obviously have a really well-established diabetes MDT that attends the foot clinic. And so there's a bit of, making sure that we're not treading on toes and finding that cohort of patients who might be more beneficial for a pharmacist review. Obviously, there's lots of things to do. So I think there is probably that cohort that we could take on. It's just kind of deciding what that might be, and also building confidence in the staff. Obviously, Nicola Butler, who's one of my senior diabetes pharmacists, has an extensive knowledge, but some of our band 7 pharmacists that come in, they've never done diabetes before, they've just moved on to their new rotation, and we need to make sure that what we're doing is safe, as well as obviously efficacious. So how do we build that competency? And just to highlight really that pharmacists do have an integrated career and competency framework, and in there is information on how they build competency within foot care, and also how they develop competency around risk factor management and cardiovascular risk, and also around sort of neuropathy management of that and the pain management pathways. So within the managing of comorbidities, really one of the things that came out of some of the data was that the pharmacists were really handy to have around to advise on things like renal dosing, and developed some really useful resources, and access, and enabled access to resources for renal dosing for patients, particularly around very complex patients such as dialysis patients, both peritoneal dialysis and hemodialysis patients. Also hepatic impairment, obviously less of that seen in the clinic, but again, advice around transplant patients and people with hepatic impairment, and also just that polypharmacy advice around drug interactions, adherence, adverse effects, contraindications, and doing the drug counselling and administration instructions to help sort of free up time in the clinic, as well as obviously being experts in medicines. Within antibiotics, they've facilitated making sure that we're up to date with which pre-packs of antibiotics we should have, and working with our antibiotic teams. I think that it was mentioned about the importance of antibiotic pharmacists, but obviously they couldn't be in an MDT on hand, but actually, have again that links to other pharmacists through a pharmacist can be a bit easier, to kind of close the loop a little bit on that. Also organising things like OPAT and CVAS, and also making sure that we can discharge patients out of area, which can be quite complex, and there's sort of higher risk antibiotics as well, which are a little bit more difficult from a monitoring point of view, things like linezolid, and making sure that patients are followed up appropriately from a blood test point of view. Analgesia pathways have been developed as part of this program of work, including kind of neuropathic pain pathways, and basic sort of pain pathways as well for sort of acute pain. And we've done lots of CPD in teaching and signposting, so we've really highlighted what might be best practice in the areas that people might be less familiar with in their own professional fields, and things like lipids, which is a rapidly expanding field in its own right, dosing and renal impairment, drug interactions, anticoagulation, and sort of highlighting some of the key publications that have come out and having those discussions on research and around the medicines, and also submitting new formulary requests as well. As we all know, we love to fill out formulary requests, they're unwieldy, so it's nice to have a pharmacist on hand to help you fill out the paperwork and make sure that all the boxes are ticked and advocate for your cause as well. Governance, this is something that pharmacists seem to attract as well. So again, I've said about formulary submissions, also procedures and protocols around medicines, and also risk assessment. So we've worked closely with other clinicians on sorting out VTE risk assessments in our limb salvage clinics, and for those with Charcot, and those needing offloading casts. What have been the limitations of this work? So patient flow has been somewhat of a problem. I think there's quite a bit of dead time, which in my experience of this has always been a bit of a problem in foot clinics sometimes. So I think thinking about, can we do some of these reviews virtually? Might it be better to follow these patients up at another time when they've not been bombarded with a lot of other information? We can still see them. We know that they're very high risk, but, is there room now, and as we work in this virtual world, to do a more streamlined approach to this? We need to avoid duplication. Obviously, that there is crossover between what we can all do, and depending on competence and confidence, but kind of highlighting kind of who's going to do what, and sort of thinking again around getting back around the table really and defining those roles. Obviously the test tube shortage causes a bit of a backlog, and COVID and clinical pressures. We've had some really great feedback from people. This is just a couple of the comments, but I certainly know that we are now doing a formal review of this as we pull together a business case. And my inbox was filled the day that I announced that we were going to be taking a closer look, with really, really positive feedback for the team, and all the value that they've brought, really. So it's really spectacular what they've achieved. And what next? So working with primary care to ensure that bloods are done, and that we've got all the information when somebody hits the foot clinic, rather than having to wait more time to see that and to make the interventions, and defining that cohort to be seen, to avoid duplication, as I've said, ensuring the right level of work for competency, that sort of layered approach. So starting somebody off with doing the cardiovascular management, and then looking to sort of drive home the 3 treatment targets as people become more able to manage diabetes at a higher level. The pharmacy technicians often get overlooked, and they could take on quite a lot of the technical work around some of the things that are being done in foot clinic, and so I think this would be a great role to establish, and that's something that we're certainly going to look into developing within our team. I've already said about referrals to the community pharmacists, also about the virtual review. Also, we want to work proactively with primary care. We don't want to wait for people to develop to be at their most vulnerable with foot disease. So we're going to have a look at, is there something that we can do with community podiatry, making some interventions, or even just education for them. So we're about to start some conversations with our community teams as well. And we're going to evaluate in a really much more in-depth way than I've demonstrated today, to find that continued funding, which, as we all know, can be challenging. So just another thank you to say thank you for allowing me to come today and speak on this topic. And does anybody have any questions?
Really interesting, Hannah. Thank you very much. And I think that really encompasses the way that we should be looking holistically at our patients. Certainly from the English Diabetes audit, foot audit, it was mentioned earlier that the numbers of people who weren't alive at 12 weeks following a foot ulcer, the majority had coronary complications, heart failure, and so on. And do you think that we might be able to reduce that by actually implementing pharmacy much better and looking at that holistic model?
Yeah, I really hope so, Richard. I think that, doing that population health management and really highlighting, a lot of the people who live with the most morbidity come from some of our lowest IMD areas. So the population health really lends itself to us getting to the right populations and kind of improving the health of those who have the worst health the fastest, which is really, really important, I think, to get some of these these killers down, really, isn't it? So I think it's really, really important that we do this kind of front loading, and the system is now set up to do these things. That's the point of the ICBs forming, and that we can try and share that learning across a bigger footprint, not drive postcode lotteries, etc., with some of the work that we're doing.
Yeah, and do you think that the role of the community pharmacist or specialist community pharmacist within things like foot protection services would be both helpful, but also, you mentioned patients having to go to 79 different appointments in 12 months, and actually trying to focus more so that we can reduce the amount of time they're having to spend with healthcare professionals?
Yeah, definitely. I think they move from silo to silo because people don't have the expertise. So there's a massive upskilling piece of work to do around that. So hence why I've taken on cardiorenal met. To be honest, my role is in the system is diabetes, but yet my bread and butter is cardiorenal met, because that's what I see day in, day out, and I try to manage absolutely as much as I can every time I see somebody in clinic or in primary care clinics, and when I'm doing my shadowing clinics as well. So trying to build that ability for people to see a patient and do as much as they possibly can for that person at any one contact, and building some of that expertise into a community pharmacy would be fantastic, because they're around the corner. Somebody could drop in and just have a check-in with somebody, make sure they're tolerating something, increase the dose. I think we're a little way from that, but I think it would be amazing.
Great, thank you ever so much, Hannah, for that. Very, very interesting presentation. And I think we're now going to move on to just a break. And so we will start again for the next session, the last session, at 4 o'clock. We'll see you then. Hello and welcome back to our final session this afternoon. This is going to be a presentation from one of our sponsors, Thermetrics, about their product, the Podium Thermal Foot Monitor.
We're Carl and Serena, husband and wife team. We've got a podiatry business. We've got a clinic in Newtown in Powys and Craven Arms in Shropshire. I'm a podiatrist, Carl's a foot health practitioner. We've got different backgrounds, but we work together to try and get the best outcomes for our patients. Generally, we see probably about 40 patients a week, something like that. It does vary. Majority of people are elderly. Lots of different conditions, lots of different problems, anything from sort of general toenail cutting to sort of diabetic foot ulcers and everything in between, sports injuries, musculoskeletal problems, verrucas, ingrowing toenails, infections, sort of you name it really, we get all sorts. We offer podium scanning as part of patients' initial assessment if they want it. It gives us a baseline then, so that if they come in with any different problems or any different concerns in the future, we can scan them and compare that to the initial time that we saw them and how their feet were looking at that time. And then other people, if they've presented with foot pain or a new complaint or something has changed or there's something that we're concerned about, then we'll offer them the scan there and then to try and investigate that, assess that and deal with that as it comes forward.
It's helping you to see their pain, isn't it? Even the doctor, if the doctor looks at the email, sees a scan, it's like, oh right, yeah, I can see that. The doctor feels more confident in what you're suggesting as well, isn't it?
It's the evidence base, isn't it? It's the this is adding to the picture. It's you've got that in front of you. It's measured and you can see it. The scan is instant, but also because of the colours on the dynamic scan, it's very clear to the patient to see themselves, oh yeah, that's a problem area, that's not because of the red and the green. It's very easy to understand for the patient to sort of be engaged with it as well. There's an element of patient compliance and patient engagement, because if you can show them something on a scan when they come in and their foot's painful, they're pleased because they can see, oh yeah, that's where my problem is and what it's showing. But also then if they come back and you scan them again and they've had an improvement through the orthotics, through your treatment plan, it's showing them their compliance, their engagement is working, their treatment plan is working.
It's invaluable, isn't it? You know, we couldn't do without it now.
I wouldn't be without it now, definitely not. I think it's definitely helped in terms of GP referrals as well, because private practice-wise, it can be very difficult sometimes to refer into the NHS, and you don't have the same referral pathways as sort of multidisciplinary teams within the NHS do. And it just adds a little bit of background and a little bit of sort of evidence-based backup to what you're referring about, what you're saying, and what you're asking them to act on, especially at the moment when patients are struggling to access services because everything's so overloaded after COVID. So it's showing us things that we can't see or detect as a clinician on the outside, and that really makes a difference. But also for people who've got a problem that they'd have a long wait time in the NHS to see a consultant or to have an MRI, or it would be very, very expensive to have a private assessment, scan, MRI and so on. And the podium, it's giving an instant, non-invasive, quick and relatively affordable idea of what's happening and adding to their treatment plan.
When they've seen the scan and they see the information, then when they come in a week later, a month later, and you take the next scan and there's the improvement, it makes it a lot easier for them to say, for them to understand, yes, keep taking your medicine, keep using your orthotics, because that's what's helped. You know, it's a visual, oh my Lord, it does what it says on the tin.
And thanks to Thermetrics for providing us with that presentation. And now we're going to hear about the career framework and extended role of the podiatrists from Dr. Emma Cowley, who's Senior Teaching Fellow in Podiatry at the University of Southampton and Dean of the Faculty of Pediatric Medicine at the Royal College of Podiatry. And she's also past chair of MSK UK. Thank you, Emma.
Thank you. Hopefully my screen will be showing up in just a second. Can you see that okay?
Yes.
Okay. That's great, thank you. So yeah, I just wanted to share with you a little bit about what's been going on behind the scenes that has a lot to do with what might be our future as a profession. And obviously listening to all the inspiring work today during the conference, I can't wait to see what the podiatry colleagues among us do with this tool. So I'll be talking about the new podiatry career framework as a tool for career progression in diabetes, among other things. So it could be any podiatry career pathway really, but obviously today we're focused around diabetes. So I'll just talk you a little bit through the background to it and where we are today and how you can use it in the future as part of forming the future of diabetic foot care, and obviously for those podiatrists among you to really maximise the opportunity. For those of you that don't know, there was a podiatry career framework launched in 2021. And this came about after quite a few years of work. It was instigated following the 2017 loss of training bursaries and a large piece of work that was ongoing at the then College of Podiatry to understand what the challenges were and the opportunities for the future for remodelling our profession and our workforce. Because of the pandemic, ironically, and because of lots of change going on at the time, this piece of work actually was landed in 2021 when actually we were already in the pandemic. And it was very obvious very quickly that actually this would have quite a short shelf life. There was so much change going on that we needed to move with the times. So what we saw during the period from around August 21, when this was launched, was a whole lot of reflections and demonstrations and expressions of podiatrists in action in new roles, changing roles. We saw reprofiling of services. The NHS became exclusively high risk, with a few exceptions. And we saw some new AHP policy landed across all 4 nations, AHP roles developing, moving, the evidence base constantly evolving. And we just saw this was very clearly going to be a call to action for the road ahead. How do we move forward now? We can't define ourselves how we were. We're not that anymore. Everything's changed. We also learned so much about where we want to be and what we want to do and where the opportunities lie. And so when this project came about and sort of it was time for a refresh, it was very clear that we needed to hear from everybody who was going to benefit from this potential piece of work to understand really what that would look like for the future. So The Podiatry Career Framework Refresh Project was brought about following a Health Education England then commissioned a piece of work through the Royal College of Podiatry as part of the Workforce and Education Reform Programme. This was one of 8 streams. Even though this is AHP2, it's actually the first one. There were AHP2 through to 9. I don't know what happened to AHP1, but this was called AHP2, the Podiatry Career Framework. And it extended in the data collection phase and analysis phase and writing phase from December through to March. I unfortunately had a nasty bout of COVID, which has slightly delayed the finalisation, but we're very, very close to the launch now. I was employed as a consultant on the project, just for transparency, and as you'll see, I was part of a bigger team. The piece of work has been very much with me coordinating it and obviously coming about in the analysis and writing stages, but hopefully reflecting the voices of everybody in the approach that we took. So the approach and methods that we undertook as part of this project was a stakeholder and strategic direction approach. We needed to hear from the people who were going to bring the career framework to life effectively, but we needed to bear in mind the strategic direction that was coming through policy, through white papers, through the Royal College of Podiatry's SACS report, for example. There were a number of sort of guiding lights that helped us to find a way forward. And so I was very keen to liaise closely with the Royal College to understand what their strategic direction was, and also engagement with the AHP Career Capability and Framework Lead, Dr. Stephanie Templeton, who was undertaking a piece of work that was sort of the umbrella to this piece of work. And that obviously set us up to build up from that point so that we would map well with the wider AHP landscape. The methods that we undertook were to undertake a scoping review of relevant policy so that it could be identified and then built in, to identify a number of career frameworks from other related healthcare professions as well, to do a thematic analysis on them to understand what they were saying about themselves, and using those pieces of information to bring forward a semi-structured approach to some focus groups and interviews with stakeholders. So we identified educators, clinicians and service managers, members of the professoriate, and leading people within the profession and just outside the profession that would be critical to helping us to ensure that what was formed was going to speak outside of just podiatry, but to the wider healthcare landscape. We also undertook a survey of membership of the Royal College of Podiatry as well. The focus groups clearly were quite small in number, and we wanted to hear from as many people as possible. And then finally, we ran some webinars with Q&A, so they were interactive webinars with a Q&A to help members of the Royal College to understand what was going on, why it was happening, the methods that we were undertaking, and for them to have an opportunity to voice what it was that they felt needed to be represented in the future career framework. So the results in brief, well, that was good and bad, as you can imagine. And I won't go through all of it. It was an extensive amount of information that came through in that exercise, far too long for us to be able to really do it justice here. But the negative themes that came through was a lack of awareness that there even was a career framework. And I suspect that was because we had information overload. We were prioritising other things around August, September 2021. There was a lot of change, a lot of stress, a lot of burnout within the profession at that time, just because of coping with the challenges of COVID and furlough and other challenges that we faced. But once people were aware of it, and those who had actually used it or seen it before, noted that it was quite hard to understand. It didn't seem to really have much of their voice in. And it wasn't useful for private practitioners and generalists, which was an interesting point, because in a moment I'll tell you how the first one came about, and it was interesting that voice was lost. Other comments were that it was linear, so representing careers as a linear pathway, which clearly a lot of people do not have linear careers, and that it was elitist, that it felt like if you were structuring your career, or your career was in effect structuring itself at a middle band, the generalist sort of middle band level, that was seen as lacking value, and it wasn't visible, and that the emphasis was on specialties and on the high-flying roles in podiatry, which is an enormous crime considering the number of generalists that we have amongst our ranks who are undertaking roles as kind of dams to the escalation of the problems that we've been hearing about today from colleagues who've given us their brilliant presentations. So it didn't really say much about the podiatry profession either. It didn't recognise our characteristics and our culture, our purpose and what we get out of bed for in the morning. So that was a lot of insight really following the writing of the first career framework. And to shed some light on how that came about, it started off at a workforce summit in 2017, where it was a series of instantaneous focus groups that were formed in that moment to try and understand and kickstart that piece of work that went on to form the first career framework. So an idea was put forward. It was discussed among the focus groups. We had immediate feedback, and from that point, the career framework was structured. But it was presented in a kind of almost a collation of what we have available to us as a profession to date. So, for example, you enter the profession at bachelor's level, or back then it was mostly bachelor's degree level. And then, you know, you can acquire things like independent prescribing, chartered scientist status, fellowships, and masters and PhDs and the like. So it was sort of set out in a, at this stage, this is what you might look like. At this stage, this is what you might look like. At this stage, this is what you might look like. But it was really lacking any character, and often it was seen as you needed prerequisites to get to certain points in your career. And actually, lots of podiatrists come at roles from lots of different angles. So I think they were quite right. The people that fed back into this when we did the ongoing sort of consultations as part of that first iteration of the career framework was that, yeah, okay, it was okay, but it lacked us. It didn't have us built into it. So what about the positive? Well, on the positive side, it seemed that people were glad that there was a podiatry career framework. We were right to actually put the work into having one, because apart from in the NHS, where you've got the Agenda for Change bands, or at least we did back then, you have to think historically, sort of help and guide people up a ladder, that actually it didn't seem to reflect other opportunities, particularly in leadership or in education or research, and where people wanted to foster more hybrid careers, that wasn't really reflected in the first iteration of the podiatry career framework. I think that honestly killed off people's interest as well. And when we heard back that people would engage if it was more user-friendly, I think it was probably a case of, if people could see their own podiatry careers and aspirations in the podiatry career framework, they would probably use it as a tool more, rather than sort of dismissing it as a static piece of policy. So the call there was really to make it more engaging. It does help to illustrate opportunities in podiatry, but perhaps it was a little isolating in terms of who can get what and when. So, for example, opportunities in research might be seen as something more for NHS podiatrists, less so for private practitioners. And so what we need to do is understand a little bit about how we can balance that based on some of the themes that came through in the Sachs report as well. Service managers were keen to build the podiatry career framework into staff appraisals and into job descriptors, but not be tied down. So it needed to be agile. The next iteration of the podiatry career framework needed to be agile, and it needed to allow flexibility, so changes in direction of careers. See if I can just get my speaker panel off. I do apologise. I think that's in the way, isn't it? There we are. So picture that came through as we were working through the new career framework stakeholder process was that other professions seem to tell us a little bit about themselves in their career frameworks, a bit about their DNA, what sort of defines them and how they are expressed. And so this seemed to be something that podiatrists wanted too. And so when considering what our DNA might look like, what does actually it mean to be a podiatrist, I figured that we had to understand really what DNA is about in kind of broad terms in this context. And it would mean that we share that sort of one body of DNA, so that we're one profession, but we have many expressions of that. So we represent our diversity of background, of inclusion, and to make sure that we are working and harnessing that diversity to our advantage. Of course, DNA has to be reliably replicable, and therefore ensuring the sustainability of in this case, the profession as we go forward. And any changes that happen are fundamental to our DNA, our core, if you like, work to benefit us all, the patient, the podiatrist, the profession as a whole. So that was sort of the backdrop of where we went next with the career framework. So working with a 4-stranded cord model then, I was reluctant not to steal from Watson and Crick too much, but it does kind of work. And I think it's important that we now kind of mobilise the 4 pillars. As you can see, these are quite reminiscent of the ACP 4 pillars that you'll be very familiar with. So we have clinical practice, facilitated learning, research, development, innovation, and leadership management that came through as preferred sort of expressions in the stakeholder groups. So these are effectively the 4 pillars, but they are about to be intertwined and woven into something more meaningful as one expression of a podiatrist. So not to leave us with a mess, but instead to understand that on their own, each of these strands, each of these cords is kind of weak. It needs to basically be entwined with the others so that they can support and enhance the other strands as well, and that each podiatrist becomes a sum of their strands together. But of course, the pattern of entwinement could differ from podiatrist to podiatrist. As we saw in the last slide, that was one example of how they had been sort of knitted together. But it might be that each podiatrist's expression of their 4 cords might be a little different. And that the length of the individual strands might sort of indicate the level of attainment that a podiatrist has achieved within their journey. So if you take, for example, in diabetes, you might start out as a graduate, but you might go on to do some additional training at graduate level, but broadening your scope before jumping up to level 7 and maybe doing a master's module. So the length of the strand would indicate going up the levels. However, what came through as well in the focus groups was that it was really important that we value and understand better the impact of generalist podiatrists working in enhanced roles, who are, like I say, acting as that sort of the dam to the complexity and the escalation of problems in multimorbid and comorbid high-risk patients. So in that respect, the depth of the colour of these strands becomes important. If they're a little sort of light, it might indicate that somebody has passed an exam but hasn't got any lived experience yet. They're not expert in applying that knowledge and the skills yet. So we could colour these strands differently over time, going from pale through to a darker shade to understand what experience and expertise might look like if one was to characterise themselves in this way. Likewise, the breadth of the strands helps us to understand as well. So rather than having each of the strands the same width, if we start to add CPD, for example, at the same level in clinical practice, we're going to get a thicker and a thicker clinical practice strand and maybe a remaining thinner but graduate level other strands that will make up that cord together. So as you can see, it's understanding sort of pictorially how we represent ourselves using this 4-strand model and mobilising those 4 pillars so that we can understand what our own profile might look like. So yeah, each podiatrist is a cord, and together we then form the fabric of the profession together, and that's how we begin to understand what our future might look like. And so quite simply, it does start with each of us. The personal podiatry profile is the working title at the moment, subject to drafts becoming accepted, of how we will start to understand what each of our own personal strands and cords look like. So the new podiatry career framework includes an interactive element, so it's more user-friendly and it's more engaging, responding to the feedback from the focus groups. It starts off with, where do I want to be? So even understanding that you might have an aspiration is important, and then to put that into words and understanding what that might look like for you as a podiatrist. So then it's about, you know, what is the profile, the personal podiatry profile that I would need to look like to fit that role. So assuming the role has some requirements, where are my gaps and how do I get there? And then how long is this going to take? What are my strengths, weakness, opportunities and challenges going to be in that process? And what are the steps that I need to take to achieve that career goal? And therefore, what is my next step now? And when can I review this and keep going with that journey? So it's very much a personal journey. It's about you identifying where you want to be, understanding the requirements of that goal, and then going about setting about your journey in a meaningful way to achieve that, to achieve job satisfaction and hopefully reduce then any attrition problems that we might have associated with the profession. So at this stage, I wanted to sort of give an example of role profiling as well. So this would be a generalist podiatrist. And as you can see, we've got the 4 pillars, if you like, across the bottom, the 4 coloured strands, but they're very pale. So this would be somebody who's passed exams but hasn't been to work really yet. They are very young, very early in their journey. If you look at the bottom, the same 4 pillars are there and at the same level, level 6, which is the degree level. But the colours are now deeper. There is an increase of experience and expertise along the way. Then if we looked at a highly experienced generalist podiatrist, now we're seeing a deepening of the colours, but also a slight broadening as well. Oh, sorry, no, that's in the next one down. So we're seeing a change in the colours again. So let me just flip back. We've got lighter, mid, and then darker. So that indicates the level of experience and expertise. And then the lower figure just there shows an enhanced graduate podiatrist. This is somebody who is still basically operating at the graduate level academically, but bolting on additional elements of scope of practice. So they might, for example, be undertaking corticosteroid injections. They might have done the minor skin surgery course at the college, and they'd be expanding sort of sideways, but without jumping up to master's level. And so, as you can see, you've got basically 3 paler blue columns here indicating the blue strands, the clinical practice, and 1 of each of the others. So that's a thicker strand, if you like. The clinical practice is a thicker strand than the others. So then what would role profiling look like in diabetes then? So assuming that we are taking the same model forward, you can see here we've got somebody at the top who would be a specialist podiatrist, someone who's been out of uni for a few years, they've built some experience, they've done some additional scope of practice training, they've got some mentoring under their belt, they are looking very much competent and comfortable in that role now. To jump up to the advanced level at band 7, you can see now they have taken those strands forward. They've lengthened their cord, effectively going up to level 7. They've still taken that experience and expertise with them. They're not focusing in all of the areas to the same extent, so their leadership and their facilitated learning is still at level 6. That's fine, but they are working hard to build on their research and their clinical practice strands. So their cord is beginning to look a bit more like that profile in that particular job, should that job look like that, that job description look like that. So what we need to do now is to think about, how will I construct my career journey and my cord? How do I know where to go and how to get there? So the capability and competency frameworks and special advisory groups, interest groups, mentors, coaches, all sorts of resources are going to be critical to this journey. And the new podiatry career framework has some appendices to point people towards those resources. Been delighted to hear today about some of the others that are developing. They sound absolutely future-facing and fantastic. This would be an example for somebody perhaps in diabetes who may choose to select the integrated diabetic lower limb care capability framework as one of the ways that they are going to understand what's required of them to get to the next level, and then to start planning beyond that. You can pick several capability frameworks, or maybe look at the job description itself and map that in particular and build this in underneath that job description. So being critically reflective is going to be critical to this whole process working well, because you have to start with where am I now and where do I need to be. So it's an honest appraisal of who you are right now and what your level of capability is. And the frameworks that we have available to us, capability, competency frameworks and so on, are a lovely mirror. They're a way to look at that and measure where am I now and where do I need to be, where are the gaps, and where am I strong and where am I weaker. And so that needs really to be more of a formal side of it that could maybe come through in supervision. But it's not to negate, obviously, all of the reflections that we can have as clinicians from time in clinic, writing up case studies, attending special interest groups, being engaged with that, gaining the latest insight onto the sort of the bleeding edge of your particular subspecialty, and making sure that you are surrounding yourself with people as well who are going to network you and make sure that you get the opportunities you need to move forward. And so this is what one of those PPPs might look like. So if we start off in the first column on the left, we've got all of those questions we were just asking. And then in the first date column, we can see where this person is right now. They're band 5, they want to be a band 6 in diabetes. They've identified that to get there, they need to look at the capability framework for integrated diabetic lower limb care. They might choose others as well. They anticipate that based on where they're at and their own personal circumstances, it might take 2 years to fulfill that sort of skills uplift and knowledge uplift. And they've chosen to identify in particular that a training in enhanced debridement, biopsy training, and maybe joining FD UK might be part of that journey. So they've identified next steps, decided that that can be done in 6 months, and then you've got the next column across where they've reviewed that. So the first few rows are the same, but now we can see that as they've come down, they've now ticked off on the previous column that they've done IRMA and joined FD UK. They're now moving on with their journey, and they can then see their cord building and their journey developing towards their career goal. But it's not hanging them. They can change it if they want to. It's just a helpful guide and a helpful tool. And then maybe once they've done that, here we are at the end of the 6 months and then 18 months, they've met their 2-year goal. They were able to secure a band 6 in this case, and now they said they want to be band 7. And so it goes on. So that would be an example of how this might work. And my call to action for you is just to think and reflect right now about how your 4-strand cord might look like. Are you currently quite low in experience? Are you just out of uni, or are you midway in, or are you really quite very experienced and sort of understanding your role as an expert in the field that would be easily measurable against all those capability attributes? Are you still practicing at level 6 and expanding and deepening into that, or have you decided to take a more vertical route through master's study, PhD study and the like? And have you stuck with your generalist role, or are you building that out now into extensions of scope, so an enhanced podiatrist role or an advanced podiatrist role or up to consultant? So how many of those extensions of your pillars, and have you done that in research? Have you done that in clinical practice? How does yours look, and how would yours look now? So that's a whistle-stop tour of the new podiatry career framework and where we're at. Look out for it. It will be launched this year and hopefully quite soon. But I'd be very happy to take any questions now if you have any.
Lovely, thank you very much, Emma. That's really interesting, and I think it's something I wish I had at the beginning of my career, because
me too.
I think we all struggle to get to where we got to, wherever that may be. I suppose one question is about recruitment and retention. And do you think that actually having this new framework in place will actually be of value to the profession and keep people in the profession?
Well, we asked students that question when we were pulling together the first career framework, and then again through the scoping exercises for the second one. And I guess at that stage, you don't know what you don't know. So they're kind of like, yeah, it's good. And it's only really when you get this side of the fence, having qualified, and you're in the sea of opportunities, and you don't really know what to do. So I think it's something that students may not understand the value of at their level, but then when they graduate and they start coming into their early careers, that's when they will see the value of it more in a more real way. Certainly, we're the stakeholder groups included people mostly mid-career, who said exactly what you said. If only I'd had this when I was in that early part of my career. We know we lose the most number of podiatrists and AHPs in general in the first 2 years post-qualification. So it's a danger zone. And I think we have to really now think about career coaching, within our teams, within our region and our little sphere of influence, to make sure that we hold on to that talent and bring them forward. And they are the leaders of the future. They're the people who'll be looking after our feet. So
that's great. Thank you ever so much, Emma. Thank you. And
thank you so much.
We look forward to the publication coming out.
Yes, absolutely.
Thank you. So to sum up from today, we've had, I think, some really interesting presentations and some discussion. I think we probably all will run away and have a look at our pathways now. Certainly looking at the background to what's come out of the English Diabetes Foot Care audit and the work from Nicole's work from NHS Resolution. I think we've got some way to go before we can start looking at all legs, but maybe actually defining things just as diabetes and lower limb care. We need to think about lower limb care generally. When it comes to who should be looking after it, it seems that actually it's a multidisciplinary foot team, and we should be thinking very much about whether we include in that pharmacy, because that holistic view is really important. And for all the podiatrists out there, I think the framework that's coming forward will help in providing the leaders of the future, which is great. Thank you all for attending. If you're not already a member of the English Diabetes Foot Care Network, please do sign up. This is for all members of anybody who's interested in lower limb. So please do sign up. And I'd also like to thank all the speakers from today. It really has been a remarkably interesting afternoon. I'd like to thank our sponsors, Scholl and Thermetrics, and also the Royal College of Podiatry, who hosts the English Diabetes Foot Care Network, and their sponsors, Ergo. And lastly, but not leastly, Orange Juice Communications, who have helped to make everything run very, very smoothly this afternoon. It makes my life a lot easier when there are no gremlins in the works. And so thanks to you all. Have a lovely weekend and goodbye.